The topic for today is going to be modalities. Okay. We're going to try and cover each and every modality. We're going to cover the key features in each and every modality. We should know when to use what, which one is better, which one is for pain, what to use for what parameters to use. That is going to be important for the exam. So we're going to try and cover each and every modality that is important from your exam point of view. Okay. Let's start with modality. The first modality that we're going to start with is your ultrasound. Okay. Ultrasound uses sonic energy. We all know it's not electrical stimulation. It uses your sonic energy. Most of the modalities that we're going to do after this, it's all going to be related to electrical stimulation, but your ultrasound uses sound energy. Now, ultrasound is divided into, your ultrasound has characteristics, okay? It has two kind of characteristics. It can either have spatial characteristics or it could have your temporal characteristics, okay? Spatial and temporal. What do spatial characteristics indicate? Spatial characteristics are the one that are for your thermal effects. That means your continuous ultrasound. So whenever you are giving continuous ultrasound, it has these spatial characteristics, okay, that are used for producing thermal effect, okay? And temporal is usually when you use pulsed ultrasound, okay? Now, so continuous is going to give you thermal effects. Pulsed ultrasound is going to give you non-thermal effects. Okay, everyone with me? Perfect. Okay. Modalities is a little dry topic, so try and be more interactive so you don't fall asleep and you can keep me awake too. Okay. Now, in your, why do we need continuous ultrasound? Why do we need continuous ultrasound? Why do we want to give continuous ultrasound? Let's say that. Why would you want to give someone continuous ultrasound? Yes, to have a thermal effect, correct? To have a thermal effect, to increase the circulation, correct? And when you want to, basically when you want to release you want to relax a particular muscle, or you want to, let's say there's a contracture and you want heat, right, for stiffness. So those are the times where we need your continuous ultrasound. And pulsed ultrasound is something that you're going to need, like non-thermal. That means it's going to be more of your healing effects, okay? And we're going to do more in detail of that, okay? But we're going to pick one at a time. So your continuous has something which whenever you give continuous ultrasound, there is something we need to keep in mind. That is your BNR ratio. Whenever we do thermal ultrasound or continuous ultrasound, we have to keep BNR ratio in mind. What is the BNR ratio? BNR ratio is your beam non-uniform ratio. Okay, it's your beam non-uniform ratio. What is the beam non-uniform ratio? It is your peak intensity, okay, it's your peak intensity divided by your average intensity. Okay, peak intensity divided by your average intensity. So let's assume that we're giving ultrasound to someone, okay? Let's decide that you've decided to give 1.2 watts ultrasound to a person. Do you think throughout the duration that you're giving the ultrasound, do you think it's going to stay 1.2 throughout? Is it that accurate that it can continue to stay 1.2? No, there will be times where it will increase. There will be time that it's going to decrease. So the peak, when it reaches the highest, that is called as your peak intensity. And average intensity is the one that you're giving. That's almost the average that is going to stay, the heat, whatever what that you're giving, that is going to be average. That's your average intensity. So what is a beam non-uniform ratio? Beam non-uniform ratio is your ratio of your peak intensity divided by your average intensity. Now your normal ratio should be 2:1 to 6:1. Okay, 2:1 to 6:1. That means you can have a difference of, let's say, 2 could be your peak intensity, 1 could be your average intensity. That is okay. 3 could be your peak intensity, 1 could be your average intensity. So throughout from 2 to 6, it's okay. But what if it is 7:1, or whether it is 8:1, or whether it's 9:1, whether it's 10:1? That means your peak intensity is very, very high. Okay. That means you have an increased chance of burns. Okay. So remember, whenever we do continuous ultrasound, there is something that we need to be careful about. That is your beam non-uniform ratio. What is the beam non-uniform ratio? Beam non-uniform ratio is your peak intensity divided by your average intensity. It can range from 2:1 to 6:1. Ideal scenarios, you want 1:1. But is it possible to get 1:1? 1:1 is not possible. So the range that you should get should be between 2:1 to 6:1. Higher than 6:1 is going to cause burns. Pasha, 6:1 is not good, but it's still acceptable because it's not going to cause burns. Higher than 6:1 is going to be the one that's going to cause burns. So remember, you can have a beam non-uniform ratio that is 2:1 to 6:1, but not higher than 6:1, because if you have higher than 6:1, if you have higher than 6:1, then it's going to be increasing the chances of your burns. Okay, yes, it is within the limits. Always remember, this is your beam non-uniform ratio. Do you all know that your ultrasound, like your ultrasound, inside the ultrasound head, there is something which is called as a piezoelectrical crystal or a piezoelectrical crystal? Yes, your quartz crystal. Excellent. Yes. So you have a crystal, okay, which is there inside. That crystal, the quality of that crystal determines your BNR. So let's say if you're good, if the quality of your crystal is very high, what will happen to the BMR? BNR, it will be lower. Why? Because what did we say? Beam non-uniform ratio should be low. Okay, your beam non-uniform ratio should be low. So greater the quality of the crystal, lower is going to be your beam non-uniform ratio. If your crystal quality is poor, what will happen to the beam non-uniform ratio? Then it's going to increase. Okay. So this is this is your one important thing with your continuous ultrasound, that your continuous ultrasound is going to have a beam non-uniform ratio. It's your peak intensity to your average intensity. It can range from 2:1 to 6:1. You do not want it to exceed over 6:1 because there is an increased chances of burn. The quality of the quartz crystal determines your good BNR. So if the quality is good, the BNR is going to be low. If the quality is bad, the BNR is going to be high, causing burns. Now, if you get a question in your exam, no, this is not hotspot, Beatrice. Now, if you get a question in your exam that says that your BNR, the BNR ratio is usually written on the machine. So that what is the machine? Whenever they do checking of the machine and all, they usually put the BNR ratio there. So if they tell you that the BNR ratio of a machine has 8:1 as a BNR, what do you do? Like, let's say you have the question, what do you do? What would you do if the machine has a high BNR? You have to change the equipment. You cannot change the crystal because the crystal is inside the equipment. It's not in your fort to actually change the crystal. You have to change your modality. I mean, you have to change the equipment. You have to get another equipment, like another ultrasound machine, because this ultrasound machine is going to cause burns. You don't check it, Anushka. I think every ultrasound machine has a thing where they have to be serviced. So when the service person comes, it depends on every ultrasound machine. It's written on it. So based on that, when the service happens, they have to check all this. So the BNR will be written on the machine. So we don't really check it. Okay. Now, another important thing in your continuous ultrasound is going to be called as hotspot. Now, what is your hotspot? Now, hotspot is, now whenever you give ultrasound, does all the ultrasound get does all the ultrasound get uniformly distributed to the area that you are giving? No. So what happens? More energy is in the center of the head. So whenever we give ultrasound, more energy is going to be in the center of the transducer head rather than uniformly distributing throughout. So what happens if there is a lot of energy in the center of the head? Let's say you're giving thermal ultrasound and there is a lot of accumulation of heat inside. That means the peak intensity will be in the center, and that's called as a hot spot. The hot spot can also increase the chances of burns. So if a patient is feeling hot spot, like if the patient is feeling really hot in that area, what do we do? First answer, we always reduce the intensity. Your first answer is always going to be reduce the intensity. Let's say if there are some keywords in your question that say that, okay, the patient is experiencing burns and there is something like, okay, the coupling medium or the gel used is less. Then what do? You increase the amount of gel. Or let's say there is no option like decreasing the intensity, or there's no option like adding more gel. What do? You can also move the transducer head faster. Sometimes they in the question they put that the therapist is using a stationary technique. What do we mean by stationary technique? Okay, what do we mean by stationary technique? Stationary technique means that the ultrasound's not really moving fast, it's staying in one spot. So if the ultrasound head is staying in one spot, it can cause more burns, right? So if that's there in the question, if the therapist is using a stationary technique, then your answer will change that, okay, you want to move the transducer head. Okay, so I'm going to repeat what is hotspot. Hotspot is accumulation of all the heat in the center. Whenever you give continuous ultrasound, patient can experience hotspot. Okay, and which is why we need to decrease the intensity. First thing will always be decreasing the intensity. If there are keywords mentioned in the question that less coupling medium, then you go with increasing the coupling medium. If there are keywords mentioned like stationary technique is used, then you go ahead with options like move the transducer head fast. But if nothing is given, your first answer will always be decrease the intensity. Let's say nothing is given, no decrease the intensity, no increase in the gel, no moving the transducer head. You can also move to the pulse mode. So you decrease the intensity, it's a similar thing, right? You decrease the intensity, you're moving to the pulsed mode. Okay, that means you move to the non-thermal mode. Okay, perfect. Does everyone understand these two important things of your continuous ultrasound? These are the main two things in your continuous ultrasound that we need to know. Now, when it comes to pulsed ultrasound is always for non-thermal effects. Now, what is non-thermal? Non-thermal is mainly no heat is going to be given. Okay, now when we're doing now, the most important thing with your pulsed ultrasound is going to be your duty cycle. So we have to know what is a duty cycle. A duty cycle is your on to your off ratio. Your on to your off ratio is going to be called as a duty cycle. Now, how do we calculate the duty cycle in percentage? A duty cycle in percentage is calculated by on divided by on plus off. Okay, you have on divided by on plus off into 100 because you're converting it into a percentage. So you're going to be on divided by on plus off into 100. So let's assume you have a ultrasound that is 2 seconds on and 8 seconds off. What is going to be your duty cycle? 2 divided by 2 plus 8. That's going to be 2 by 10. That's going to be your 20%. Okay, so this is how you calculate your duty cycle in percentage anytime they give you the on and the off period. Everyone clear? So pulsed ultrasound, you have to understand. So for continuous ultrasound, you have to understand two things. One is the BNR ratio. If the BNR ratio is high, increased chances of burn. Change the equipment. If you have a hot spot, increased chances of burn. Decrease the intensity, move to pulse mode. And depending on the keywords in the question, you can either add the coupling medium or you can move the transducer head fast. That was your continuous ultrasound. For your non-thermal ultrasound, that is your pulsed ultrasound, you need to provide it with a duty cycle. That means it has to have on-off because it's pulsed. It cannot be continuous. So the duty cycle is your on to your off. If you want to calculate it in percentage, it's going to be on divided by on plus off into 100. Okay, usually when you're giving a non-thermal ultrasound, what should your duty cycle be? Your duty cycle should be 20 to 50%. It should not exceed 50%. Ideally, 20% is the best, but 20 to 50% is acceptable. It should not exceed 50% because when you're between that 51 to 99%, what is it almost similar to? So 51 to 99% is going to have some kind of heating effect, okay? So you do not want to go there, okay? So duty cycle is for a pulse ultrasound will always be 20 to 50%. Everyone clear with this? Okay. Now, whenever you give ultrasound, okay, whenever you give ultrasound, is all the energy of the ultrasound directly absorbed into the surface wherever you are given? Not all the energy gets absorbed, right? It's not possible. Like everything that you give is directly absorbed. Some of it gets scattered. What is that scattering in your ultrasound called? That scattering of the rays. Okay, scattering of the rays has a word which is called as attenuation. Okay, scattering is called as your attenuation. So your ultrasound basically gets reflected and everything. So that is called as the attenuation of the energy. Now, if someone asks you what is a structure that absorbs maximum ultrasound, okay, without it scattering a lot, what is the structure that absorbs maximum ultrasound? So any structure with a high collagen content is going to have maximum absorption of the ultrasound. So what has the highest collagen content? Your bone, right? Your bone has your highest collagen content. After your bone, you have other structures like ligament, muscle, tendon, right? Ligament, muscle, tendon, they have less collagen as compared to bone. So the maximum absorption happens in bone, and then it's going to be your ligament, tendon, and your muscles. Okay, is everyone clear? Where you have maximum absorption. Now attenuation, now your mediums, okay? Now scattering usually of ultrasound is going to happen, but you have to see which medium is going to help less scattering. So which is the medium that assists with less scattering? Less scattering of the ultrasound is going to happen in water. Okay, anything that is liquid like your blood, your plasma, anything with high water content. Okay, if you're confused, don't worry, I'm going to repeat it. Okay, nobody asks you this directly, but because you're using ultrasound, you should know this, that all the ultrasound energy does not get directly absorbed. Some of the energy gets reflected, refracted. So that is called as the attenuation of ultrasound. Now, if you're asked what structure absorbs the ultrasound energy the most, it's going to be structures which have high collagen content. That means your bone is going to be having maximum absorption of the ultrasound. And then it's going to be muscle, tendon, ligament, etc., etc. Now, if you look at a medium which is responsible for less scattering. So we are talking about a medium where scattering doesn't happen a lot. That medium helps in making sure that your rays are not getting scattered. So what medium helps us in not scatter, like in preventing the ultrasound from scattering? It's going to be any medium with a high plasma content or a high water content. So your blood, your plasma, your water, all of this is going to cause less scattering. So when you're giving ultrasound on your in your body, whatever blood or plasma is there inside, that's going to prevent it not to scatter, and the bone is going to absorb it the most. So understood what is scattering, what is attenuation, where is the maximum absorption? Everyone clear? All right. Okay. Now, this was a little boring part, but don't worry, we are coming to the interesting part of modalities. Okay, but everyone understood what is continuous ultrasound, what is pulse ultrasound, characteristics of continuous, your duty cycle. Okay, now moving on is your ultrasound frequency. Yes, scattered means it is spreading. Okay, scattering is spreading, scattering is attenuation. Okay, attenuation means scattering, spreading. Absorption is absorbing the rays. Okay, it's different. All right. Now, important. Now your questions will come on what is your frequency, what is your intensity. Very important to know that. Now, your parameters. Now, frequency. What do we decide the frequency based on? What do we decide the frequency of ultrasound based on? Very good. Based on the depth of the tissue. Okay. If the tissue is deep, if you have a deep tissue, how much ultrasound do we give? We give 1 megahertz. If your tissue is superficial, What do we give? We give a 3 megahertz. Now remember, this has nothing to do with whether, this has absolutely nothing to do whether it is an acute condition, it is a chronic condition, nothing. The frequency just is determined by the depth of the tissue. Always remember, I know we confuse a lot with acute, chronic. No. Frequency, if the structure is superficial, it's going to stay 3 megahertz. If the structure is deep, it's going to say 1 megahertz. Yes, your frequency is just going to be based on the depth of the tissue. Okay, so 3 megahertz, think about it like if you are using a fork, right? If you're using a fork, with 3 of them, it's going to be a little superficial. But if you use a pin, it's 1 megahertz. It's going to go deep inside. Okay, so superficial tissue is just 1 to 2 centimeters deep, and deep is going to be greater than 2 centimeters. That's correct. Okay, so frequency is always determined only by the depth of the tissue, nothing to do with acute, nothing to do with chronic. Okay, don't confuse this. Okay, now what structures are superficial? What do you think structures are superficial? Think about anything that can be palpated within 1 to 2 centimeter. So your wrist ligaments, your metacarpals, your DIP, your PIP, your basically your elbow, your lateral epicondylitis, medial epicondylitis, anything that you can palpate. Okay, ankle ligaments, your tendon, your Achilles tendon. Okay, things that is your Achilles tendon, things such as such things are going to be more superficial. Could you give me more examples of deep structures? Deep structures will be your deep muscle, like big bulky muscles, quadriceps, hamstring, low back, back muscles, a bursa that is inside, yes, shoulder bursitis, hip bursitis. Now, bursa cannot be just classified as deep. What if I tell you I have olecranon bursitis? Would you call it superficial or would you call it deep? Then it's superficial. So you always look at the structure, don't categorize it. Same way with tendon. If I tell you that I have a bicipital tendon problem, it is superficial or is it deep? It's deep because you cannot palpate it, right? But if you have a supraspinatus tendon is going to be superficial. But supraspinatus muscle, what about the supraspinatus muscle? The supraspinatus muscle is going to be deeper. So you just see if something is like 1 to 2 centimeters. So just imagine something that can be more palpable is going to be superficial. Something that's cannot going to be deep is something that's not really palpable. It is big, it is bulky. Okay, I will give you some random conditions and you'll tell me the frequency and the intensity. So don't worry. Yes, your capsule is deep. Your shoulder capsule, hip capsule deep. Your shoulder bursa, hip bursa is deep. Yes, it is deep. Okay. Now that's about your frequency. How do you determine the intensity? The intensity will be determined based on the condition, if it is acute or it is chronic. Okay, I said supraspinatus tendon is superficial and supraspinatus muscle is deep. How do you expose the supraspinatus tendon for ultrasound? How do they expose the supraspinatus tendon for ultrasound? You do extension and you do internal rotation, because when you put your hand like this at the back, you're going to be opening this area, and opening this area is important to put the ultrasound. It basically used to expose the area and then you to give ultrasound there. Okay, your shoulder bursa, your hip bursa is deep, but your olecranon bursa is superficial. Okay, now intensity depends on whether it is acute or chronic. When you have to look at ultrasound, always think acute is going to be less than 3 weeks. Okay, anything that is less than 3 weeks, it's going to be acute. Anything that is more than 3 weeks, okay, anything that is more than 3 weeks, okay, that is going to be your chronic. Okay, extension and internal rotation is going to be for the exposing the supraspinatus tendon for giving ultrasound. But whenever you palpate a muscle palpation comes by its action. So if I just do abduction and external rotation, I'll be able to palpate the supraspinatus tendon. Okay, so don't confuse. This is only an exception for supraspinatus, where when we want to expose it, we are going to give this position because we want to be able to roll the ultrasound head in this position. Okay, coming back to the intensity, acute is going to be less than 3 weeks, chronic is going to be more than 3 weeks. So if you have acute, What is the intensity that you give? You will always give pulsed ultrasound, or you'll give non-thermal ultrasound, pulse non-thermal, and intensity will always be less than 1 watt per centimeter square. That means it will be 0.5, 0.6, 0.7. It's going to be pulsed. It's going to be less than 1 watt per centimeter square. When we have a chronic condition, it's always going to be continuous ultrasound. It's going to be thermal ultrasound, and the intensity is going to be greater than 1 watt per centimeter square. Okay, now again going to repeat this so you don't confuse it with any question that has been asked. Frequency could always be 3 megahertz or 1 megahertz. 3 megahertz is for superficial structures, 1 megahertz is for deep structures. Intensity will determine not on a superficial or deep, no. It just is determined based on whether the situation is acute or it is chronic. Acute is less than 3 weeks, chronic is greater than 3 weeks. If you're giving, if the condition is acute, it will be pulsed ultrasound, non-thermal ultrasound with an intensity less than 1 watt per centimeter square. If it is chronic, then it's going to be continuous. It's going to be thermal greater than 1 watt per centimeter square. Clear, everyone? Parameters, frequency, intensity. Duration of ultrasound is somewhere going to be between 6 to 8 minutes. So most of the time, ultrasound is given for 6 to 8 minutes. Superficial structures means 1 to 2 centimeters. Deep structures will be somewhere between more than 2 centimeters deep. Okay, anytime you have more fat tissue, obesity, or like high muscle mass like quadriceps, hamstring, it's all going to be deep. Now, when would you give a thermal ultrasound? We already spoke about it being a chronic condition. What else? What are the benefits of giving what are the, like rather say, what are the uses of thermal effects? What all the thermal effect is going to do? Thermal effect is going to is going to increase the heat of the tissue, correct? So it will be count as 1 unit for documentation. Yes, Pasha, it is your ultrasound is just 1, yes, 1 unit. Okay, it's because your modalities are not timed. Any modality you give, whether you give it for 20 minutes or 30 minutes, is just going to be billed as 1 unit. Okay, yes, it's going to improve the collagen extensibility. Excellent. Yes, it increases the collagen extensibility. Collagen extensibility is it helps with the stretching, right? So it increases the collagen extensibility. It increases the circulation. It increases the basal metabolic rate. It decreases the pain. It basically increases the heat of the tissue. And it basically helps in the collagen extensibility, also helps in the scar formation, like when you want to break down scar mobility. Excellent. Okay, and even with like edema, when you have too much edema and you have like too much pitting edema where the fluid has become very viscous and you need to break down the protein in that fluid. Okay, then with edema also you can give like a thermal ultrasound. I'm not telling you lymphedema, remember, no heat during lymphedema. So I'm not telling you lymphedema, just in general, if you have swelling, edema, because of something like secondary, not even because of an acute condition. Let's say you just have swelling or you just have edema that's not moving around, then you could give thermal ultrasound. But again, edema ultrasound is not the preferred modality. So don't ever pick it if you have a lot of other modalities to choose. Okay, this was just, I told you as another indication of thermal ultrasound. Joint stiffness, yes, joint stiffness. And so all these are going to be your yes, it alters the nerve conduction velocity. Yes, so all these are going to be your effects of continuous ultrasound. So anytime you want to do scar mobilization, you want to help with contractures, you want to help with stretching, you want to help with pain, heating the tissue, all of this is going to be your thermal ultrasound. Okay, now joint stiffness, muscle stiffness, that's also correct. Good. Now, excessive temperature, like let's say if you have excessive temperature, there is some, and you're putting the ultrasound over the bone, what can it also cause? It can cause periosteal bone pain. It's a very sharp pain, which is called as a periosteal bone pain. What do you do if there is periosteal bone pain? Reduce the intensity. Again, always remember decreasing the intensity is going to be the best answer. Okay, so if you have periosteal bone pain, decreasing the intensity is going to be the best answer. Everyone clear? So Beatrice, edema, ultrasound is not going to be the best thing for edema. But yes, it is used for chronic edema also, but otherwise you have a lot of other modalities to work with edema. Okay. Everyone clear with the thermal effects? Now tell me, what are the non-thermal effects? So these were all the thermal ones. What does non-thermal help in? Anushka, because when you have a lot of temperature and maximum absorption takes place in the bone, so if you have very high temperature and you're putting the ultrasound head over the bone, it can give you periosteal bone pain. So it's essential to reduce the intensity. Okay, your non-thermal effects are going to be, okay, it's going to be cavitation, acoustic your acoustic microstreaming, correct? Okay, now what is this helping in? What is all this cavitation and acoustic streaming and all that helping in? What is it helping in? It is helping in healing of the tissue. So that is why it basically causes an alteration in the cell membrane permeability, and it helps in increasing all the macrophagic activity. It increases protein synthesis. It increases tissue healing. So non-thermal effects are always going to be related to tissue healing, protein synthesis, increase macrophagic activity, increase in your alteration in your cell membrane permeability. Okay, so that is something that is going to help. That is going to be helpful for your anybody with an acute injury. So when you have an acute problem, we always give you non-thermal ultrasound. Now somebody asked me, what is acoustic streaming? Acoustic streaming is just on your cell membrane. You have the movement of the fluid. So this movement of the fluid, like a normal membrane, like normal movement of the fluid, is essential for wound healing. Okay, it's essential for your wound healing. It increases the cell membrane permeability. But if it is altered, it's going to affect the healing. So all this, what this non-thermal ultrasound does, it basically accentuates all this. Okay, so that is why it's going to help with the healing. So everyone understood the uses of thermal ultrasound, uses of non-thermal ultrasound, all the ultrasound parameters. Perfect. Now, yes, so whenever you have any acute injury, it's better to always go with non-thermal pulsed ultrasound that is less than 1 watt per centimeter square. Perfect. Now comes the procedure. Okay, procedure is also important. We should not neglect. Everything in ultrasound is very important, which is why I took it as a first one. Okay, now, whenever you give ultrasound, it is essential that it is essential to make sure that you don't spoil the machine. So it is important that you apply gel before turning the machine on. So gel must be applied before turning the machine on to prevent damage to the crystal that is inside. How do you place the ultrasound? The ultrasound is placed perpendicularly at 90 degrees over your surface or over your skin. It is basically placed at 90 degree. The ultrasound head is at 90 degree, touching the skin with the gel in the middle. Okay, your strokes are going to be small. Okay, they're going to be small, one circling over the other, right? That's how your strokes are going to be. So you may have circular strokes, one half covering the other. So let's say, how do I explain that? So if this is one stroke, the other stroke will be like this, and the other stroke will be like this. So you are overlapping. So this is how we give ultrasound. Either you give it in a circular pattern, or like that's a small and rhythmic pattern, or you are giving it into a cylindrical pattern. Okay, so you can give it like longitudinal, or you can give it small and circular. Okay. Now, so direct coupling agent we know is a gel, right? We apply the gel to the transducer head and then we place it on the skin, and then you're going to turn the machine. But not always direct coupling is used. Sometimes we use something which is called as a underwater technique. So when do we use the underwater technique? Whenever you have like small distal joints that are irregular. So name them. So let's say you have your ankle, okay, or I have my wrist, or I have my MCPs, or anything which is small, irregular. Is it easy to just dip them in water? Yes. Okay, so it is easy to dip them in water. So whenever you have small distal joints that are irregular in shape, we are going to use the underwater technique. So with the underwater technique, you use a basin. What should be the material of the basin? It should be plastic or it should be rubber. You cannot use a metal basin. No, it should be either plastic or it should be rubber. When you are using an underwater technique, do you put direct contact? Do you put direct contact of the ultrasound head to the surface? No, you're going to keep it again perpendicular. Perpendicular is important, but now you're going to keep it at a distance of 1 centimeter. Okay, so you still keep it perpendicular and you're going to keep it at a distance of 1 centimeter. Now, another thing in underwater technique is, do you require more intensity or do you require less intensity as compared to direct contact? Yes, your intensity is going to be more because it's no direct contact. So you have to increase the intensity. Okay, so your first was your direct contact. Direct contact, you use gel or a coupling medium. The ultrasound head was perpendicular to the skin, and then you increase the intensity. The second technique that we did was an underwater technique. Okay, underwater technique is used for small distance joint or irregular joints. You're not going to use a direct contact. It's going to be held 1 centimeter away, again perpendicular, and your intensity is going to be higher than a direct technique. You have one more, which is, let's say for example that you have an acute shoulder let's say you have an acute shoulder problem, okay, acute shoulder intensity, acute shoulder injury, and when I put the ultrasound head, I make the ultrasound head contact with my AC joint. I cannot take the pain. I cannot tolerate the touch of my metal head because my ultrasound head is metal, right? So when I cannot basically tolerate the ultrasound head, what do I do? Can I still use direct technique? I cannot use direct technique anymore because it's not coming in contact. I cannot even use underwater technique because I cannot dip my entire shoulder in water. So I'm going to use like balloons, water balloons, or gloves that are filled in balloon, and I'm going to put that glove here. Over that, I'm going to put my ultrasound. So what did I tell you all earlier? Remember, that is why I explained that part. Where does the ultrasound scattering happen the least? Where does ultrasound scattering happen the least? Water, which is why when you give water medium, it is acceptable, right? Which is why when you give a glove that is filled with water, what will happen? The ultrasound is going to penetrate here. That is when, so that is again an indirect method of coupling. Okay, everyone understood? So you can either use plastic or rubber. Underwater, you use a plastic or a rubber basin. You can never use a metal basin. Okay, so direct contact with your gel. Okay, make sure that before you put the machine on, there is already gel on the head. The indirect is going to be either using water balloons or water gloves filled with water for something that is acute or tender where you cannot tolerate direct contact, or you use a underwater technique for small irregular joint surfaces. Okay, so this is your procedure. Your strokes are going to be either longitudinal stroking or small circular stroking in a rhythmic pattern where your one is overlapping the other one. Okay. Now, one more thing in your ultrasound is for indirect method is coupling required. Crystal, for indirect method, you don't need gel. You do not require to put gel. Your water is going to be your medium, so you don't need to put gel. Now, one more thing that you have is your ERA. What is ERA? ERA is an effective radiating area. It's an effective radiating area from the transducer head. So if I have so let's say if I have a size, my head size, my ultrasound head size is 5 centimeter. Okay, I can provide ultrasound. Okay, I can provide ultrasound to an area that is 2 to 3 times my transducer head area. Okay, so 2 to 3 times your transducer head area. So if your transducer head is 5 centimeter, how much is the maximum area that you can cover? 2 to 3 times. So it's going to be 10 to 15 centimeters. So if whatever is your effective radiating area, you can only cover an area that is 2 to 3 times approximately. You cannot exceed more than 3 times. So if your transducer head is 10 centimeter, you can cover an area that is only 20 to 30. It's only going to be a 20 to 30. It's not going to be more than that. What if you have to cover an area which is 50 centimeter, but you are given a 10 centimeter transducer head? What do we do? you're going to break down the session. You cannot give one. So you're going to divide the area. You're going to divide it into two parts. You're going to give one ultrasound to one part, and then you're going to give the ultrasound to other part. Yes, so you break it down. You cannot just aimlessly move the ultrasound head over the entire back. It's not going to cause any effect. So if we do that, then we should not do that in the clinics because there is no use of it. Okay. Everyone clear with this? If you have very less heat, let's say a patient is feeling very less heat, what could be multiple ways of like improving the heat? You either are moving your head too fast, so you can move your head a little slow, or your intensity is too low. It could be either one of the reasons. What if the patient is feeling too much heat? If that means you decrease the intensity, that means either you're not moving the transducer head fast or your intensity is too high, right? Okay. So quick recap, what all did we do? We did what is your characteristics of continuous beam non-uniform ratio, and your hotspot were important. In temporal, we decided how to calculate the duty cycle and how much duty cycle do we need for your non-thermal ultrasound. Okay, then we discussed your frequency, 3 megahertz, 1 megahertz, when to use. Then we discussed the intensity, when to use less than 1 watt per centimeter square, greater than 1 watt per centimeter square. We discussed your uses of thermal ultrasound, uses of non-thermal ultrasound. We discussed the procedure with direct coupling, with indirect coupling also. And we did the effective radiating area. So your duration, if you're giving 2 parts, your duration will also be divided there. So you could give, your duration is not going to be completely divided because it's not going to be that effective. If you give if your ultrasound duration is 6 to 8 minutes, you can give 6 minutes, 6 minutes. Okay, you don't need to give full 8 minutes or 10 minutes. You can give 6 minutes, 6 minutes, but you don't want to go less than that because again, it's not going to be effective. If you do 3 minutes, 3 minutes, it's not going to be effective. Okay, now everyone with me? Everyone understood so far whatever we've done in ultrasound? Contraindications. What do you think now? Okay, now tell me what all do you think are the contraindications? Most of your conditions are going to have everything same. So let's do it properly this time. So next conditions we can skip. What are your contraindications? Okay, pulmonary embolism, malignancy, very good. Impaired circulation, good. Vital or anywhere near your vital organs like your brain, eye, reproductive organs, over your carotid sinus, over your genital areas, over your eyes, malignancy, tumors, infection, impaired cognition. Okay, yes, or you have open or exposed spinal cord, somebody with epilepsy, somebody with your joint cement, or someone with your like breast implants. Yes, you do not give it. But now, yes, your epiphyseal, over the epiphyseal growth plates in children, because that can cause early fusion. Yes, thrombophlebitis, DVT, okay, all of this, yes, it is very, very important. Now, let's think about some stuff that is relative, okay? Now, again, I'm going to repeat, and I'm going to keep repeating this again and again. Contraindications, relative contraindications in your modalities are very, very tricky. Okay, they will put the same thing under precaution, same thing under contraindication. How do you recognize what is important? You have to look at what is safe. Okay, now if they ask you what is an absolute contraindication, you know your absolute contraindications are definitely going to be cancer, or they're going to be over vital organs, or directly over the carotid sinus, or thrombophlebitis, DVT, vascular problems. Those are going to be your absolute contraindication. But there are some things which need not be absolute contraindications. Let's say pregnancy. For pregnancy, you don't give it on the lower back, but can I give it in the hands, the ankle? I can, right? So that is why that will become a relative contraindication. Okay, now plastic implants is absolute. That's correct, because plastic implants can melt. So plastic implants is absolute. Even though you use a plastic basin while giving underwater technique, your plastic implants is going to be an absolute contraindication. But what about metal implants? Is it absolute? No, you can give ultrasound in metal implants. You just have to make sure the intensity is not too high and you are giving your pulsed mode. So you can give your metal implants. What about pacemakers? What about pacemakers? It's you don't give ultrasound near that area. Okay, it's just sound energy. So you don't give it near the shoulder, near the chest region, but can I give it in the low back? Can I give ultrasound to a person with pacemaker on the low back? Yes, you can give ultrasound to a person with a pacemaker on the low back region. Now, if you have, okay, sometimes precautions can be if you have a very acute injury, okay, and any touch is also very painful, then okay, ultrasound, you won't be able to touch the ultrasound head. So maybe as a precaution, you can use like an indirect coupling, like a water balloon or something like that, okay? Now, over your epiphysis of the growing bone. So let's say there is a teenager, okay, and his bones over that bone, is it an absolute contraindication or is it a relative contraindication? Relative is similar to precaution. This will become a precaution. Why? Because whenever you give it over the epiphyseal growing bone, okay, it causes early fusion. Now, why does it call early fusion when you are actually giving continuous ultrasound? So researchers have shown that when you're giving continuous ultrasound, that increased blood circulation up there, everything that increases causes the early fusion of the bone. Okay, yes, over epiphyseal growth plate, it's the same thing as your epiphysis. So when you're growing bone, that epiphyseal growth plate is still like growing. So giving pulsed ultrasound is actually okay. But giving continuous ultrasound is what should be absolutely contraindicated in such a condition. Okay, why am I explaining you this? Because in your exam, let's say you have epiphyseal growth plate and if you have cancer as an option, which one will you pick as an absolute contraindication? Cancer. Okay, so in your modalities, you see different books, you see Cameroon, you see therapy, everybody will have differences in precautions, everybody will have differences in contraindication. What you need to do is we need to make an educated guess when it comes. We are studying the condition, so we know what is going to be safe to pick over what. Okay, now there was a question, I think somewhere, I don't know which practice exam, but this was a question where they asked which one would you give ultrasound with precaution, or which one would you give ultrasound with precaution, which one can you give ultrasound with precaution, and they put all the absolute contraindications in there. Okay, yes, that's correct, Pasha. So epiphyseal, you do not give absolute, you do not give continuous ultrasound, but if there is an option of pulsed ultrasound, it can be given. Okay. Now, in your question that I was talking about in a practice exam, there's a question in which they say which of them you can give ultrasound with precaution. And let's say your options are everything related to absolute contraindication, like impaired sensation and let's say DVT or a vascular problem. Now, which one would you pick? Now, everything is absolute, right? But they still gave it to you in the exam that which one will you pick with, which one would you do it with a precaution? Then you have to look at impaired sensation, because even if you put it like you give non-thermal, it's fine, right? If you give non-thermal, it's not going to cause burns. But can you give it over a vascular problem? No. So exactly this way, like exactly how you guys made a guess here, same way when it comes in the exam, don't tell yourself, oh, in the book, this is given under relative. Oh, in the book, this is given under absolute. No, there may be times where everything is wrong. Nothing is safe, but they will check what is your reasoning behind it, and which is why they give you such questions in the exam. So be vigilant before you pick an answer. Okay, everyone understood now? Okay, always do that for modalities. It's very important. Otherwise, you're going to get into that vicious circle you're going to get into that vicious circle of memorizing. Sarah, impaired sensation is not really okay. But if you are going to be asked to pick out of all the worst options, impaired sensation is going to be slightly better than a vascular or a DVT problem, because you can give non-thermal mode and still the patient's not going to have burns. Okay. No, ideally for metastasis, for cancer, you don't give anywhere. For metastasis, we always be safe because we don't want the metastasis to spread. So you are not going to give it for anything. I always tell everything in your exam is not going to be related to your books. You won't find the exact same answers that you are studying. Sometimes you have to, sometimes you have to choose best over your worst. Okay, sometimes you have to choose your best out of your worst. Like all four options are bad, but you have to choose the best out of it. Okay, that's correct, Dhruvi. And Anushka, if it's non-metastatic, but if it's malignant, you will not give ultrasound, whether it's metastatic or it's not metastatic. If it's a malignant one, you will not give. Benign, it's fine. Benign is not going to cause, it's just like a growth of tissue. So that's not going to be a problem. Everyone clear? What to do when it's too hot, when it's not hot? We discussed all of that. Right? Now, ultrasound is also used to diagnose stress fractures. Again, this is not like a very, this is not something that is like a very important indication of ultrasound, but yes, ultrasound does help in diagnosing stress fractures. Okay, it's basically used in an underwater technique. So when ultrasound is given over the fracture site, if you move the transducer head in water over the fracture site, the patient is going to complain of sharp periosteal pain, and that determines that, okay, this person has a stress fracture. Again, they won't ask you that because we don't really do that, but still, okay, for stress fractures, you can use an ultrasound to detect stress fractures. Okay, yes, Joanna, you can use bone scan for stress fractures. You can use CT scans also to determine stress fractures, but yeah, bone scans are good. Okay, everyone good with ultrasound so far? Now, one more thing that is there is something which is called as a phonophoresis. What is phonophoresis in ultrasound? Pasha, it completely depends on what you're trying to do. And anyways, for pacemaker, you will not give any electrical stimulation modality. So ultrasound can be given because it doesn't have a current. For pacemaker, if you are on a pacemaker, you can never give electrical stimulation. You should not be given for a patient with a pacemaker because the electrical stimulation, the electrical impulse interferes with the impulse of the pacemaker. So you cannot give any current when a patient is on a pacemaker. Ultrasound is okay because it's sound energy. Okay. Yes. So when you want to transfer medication, via the use of sound energy, via the use of ultrasound. It's called as phonophoresis. Basically, for transmission of your medications in the deeper tissue, in the superficial tissue, everything is going to be similar to your ultrasound. Same parameters: 3 megahertz, 1 megahertz, 3 for superficial, 1 for deep. Acute or chronic, depending what is the situation. If it's a chronic, it will be greater than 1. If it is acute, it will be less than 1. Okay, and usually you are going to basically mix the medication. Basically, your medication is going to be mixed with a material that is a good conductor, like your gel or anything that is water based. So like a good conductor, the medication is mixed and it is used as a coupling agent. So that will help in the transfer of the medication inside the deeper tissue. So that is phonophoresis. So whenever you want to transfer the medication into the tissues with the use of sound energy, you can use your phonophoresis. Okay. Everyone understood with all the key points in ultrasound? Before I ask you what is the parameters, I want to make sure that you all are clear with ultrasound uses, this contraindications, precautions, your indications when we use thermal, non-thermal characteristics, duty cycle. Okay, that's clear. Perfect. Now, let me ask you some conditions. I want you all to write your answer on the chat box, like both your frequency and your intensity. So I want you to put both in the chat box, okay? So if I tell you the patient is having frozen shoulder for 1 month, what will be the intensity? What will be the frequency that you are going to give? Excellent. It's going to be 1 megahertz and greater than 1 watt per centimeter square as the intensity. Not 3 megahertz, it's going to be 1 megahertz. The shoulder capsule is deep. I think you may have come across a question in the mini exam that I think says the shoulder capsule is superficial. That's an error there. We need to correct it when we're trying to make that change. but your shoulder capsule is going to be deep. Okay. If you have a supraspinatus muscle strain for the last 1 week, supraspinatus muscle strain for the last 1 week. AC joint is 3, Joanna, because you can easily palpate your AC joint right here. So when anything is superficial palpable, it's going to be 3. So yes, supraspinatus muscle, the muscle strain in the last 1 week. So it's a supraspinatus muscle, so it's going to be, it's a muscle, so it's going to be 1 megahertz because it is deep under the trapezius muscle, and it is for 2 weeks. So is that acute or chronic? 2 weeks. It's going to be acute, so it's going to be pulsed mode, that is 20% duty cycle, right? So it's going to be pulsed mode, that means less than 1 watt per centimeter square, and your frequency is going to be 1 megahertz. Okay. What about a biceps muscle strain for 2 months? 1 megahertz greater than 1 watt per centimeter square. It's a biceps muscle strain. Biceps is a big muscle, bulky muscle. It will always be 1 megahertz. What about a hip bursitis for 1 week? Hip bursitis for 1 week. 1 megahertz less than 1 watt per centimeter square. It's a hip bursa. It's not superficial, guys. Do you feel a hip? Do you think hip bursa is within 1 to 2 centimeters? No. Achilles tendonitis for the last 2 weeks. Achilles tendonitis for the last 2 weeks. 3 megahertz less than 1 watt per centimeter square. Good. Obese patient with medial epicondylitis for 1 week. Obese patient with medial epicondylitis for 1 week. Obese patient with medial epicondylitis for 1 week. So 1 megahertz because there's more fat tissue and less than 1 watt per centimeter square. Good. Now you guys are getting the hang. Okay. Now, anterior talofibular ligament sprain for 1 week. 3 megahertz less than 1 watt per centimeter square. Perfect. Okay, one more. Let's do one more. Low back pain for 1 month. 1 megahertz deep muscle greater than 1 watt per centimeter square. Everyone clear with ultrasound now? You feel good about this modality? Anything acute is going to be less than 1 watt per centimeter square. If a muscle is deep, it is 1 megahertz. If a muscle is superficial, it's going to be 3 megahertz. There is no discrepancy in that. Don't look at acute, chronic, and decide your frequency, please. Frequency will only be determined by the depth, and intensity will be determined by acute and chronic. Okay. Obese example, it will become deeper. So it's going to be 1 megahertz. But if I would have not said obese, then my medial epicondylitis would have been 3 megahertz. Okay, let's move on to the next modality. Iontophoresis. Okay, and now we come to all the modalities that use current. Okay, that use current, like your electrical stimulation. Okay, now what is iontophoresis? Let's look at what is iontophoresis. So we're gonna, for every modality, we're gonna be like, what type of current it is. Okay, what is the waveform? So what is an iontophoresis? Always remember, iontophoresis is your continuous direct current. Okay, it's your direct current. What is your waveform? The waveform is going to be monophasic. That means iontophoresis is going to be like this. Okay, it's going to be a monophasic waveform. Okay, and it is going to be a continuous direct current. Okay, other characteristics, it is low frequency, low amplitude, and low voltage. So iontophoresis is a current which is low frequency, low amplitude, and low voltage. Okay, low frequency, low amplitude, and low voltage. So can I call iontophoresis as LVCC? Low voltage continuous current. Can I call my iontophoresis as a LVCC? Yes, because it's a low voltage continuous direct current with a monophasic waveform. Now, what is the principle that we use in iontophoresis? The principle that we use in iontophoresis is that like charges repel each other, like charges repel each other, opposite charges attract each other. So if it's positive negative, it will get attracted. If it is negative negative, it's going to get repulsed, right? Repel. That is what is our focus here, okay, which is why we have ions. Now, ions in iontophoresis are extremely important. Most of the time in the exam, one ion is going to be asked. How do we remember the ions? How do we remember the ions? We always remember the negative ions. The negative ions are going to be your SED ions. That is your salicylate, acetate, iodine, and your dexamethasone. Remember the action of each and every, remember the use of each and every ion in your exam, very likely. Okay, what is the use of salicylate? Come on, you guys, it's your test. What is the use of salicylate ion? Pain. Okay, it's going to be for pain and analgesia. Is salicylate an anti-inflammatory? No, very good. It's just an analgesic. What is the use of acetate? Acetate is your calcium deposition. So can I use it for calcific bursitis, calcific tendinitis, or myositis ossificans? Yes, I'm going to be using it for these conditions. What is iodine for? Iodine is for softening of your scars. So you're going to use iodine for any kind of hypertrophic scars, keloid scars, when you want to soften it, or sometimes when there is like frozen shoulder and there is excessive of scar tissue, like which frozen shoulder, that time you can give it. Dexamethasone. What is dexamethasone for? Here it is an anti-inflammatory, okay? So only these four ions, that is the SED ions, are going to be negative. Rest all the other ions are going to be positive. What is xylocaine, lidocaine for? Lidocaine, xylocaine for? Pain and analgesic. Good. What is hyaluronate for? Hyaluronate is for edema reduction. Okay, it's your hydration. So it's going to be for your edema reduction. Calcium, magnesium. Muscle spasm. Zinc. Dermal ulcers, your wound healing, your dermal ulcers, that's going to be zinc. Copper. Copper is going to be for fungal infections. Silver. Silver is going to be for bacterial infections. Copper is going to be for fungal infection. Silver is going to be for bacterial infection. There is one more that's called as lithium. What is lithium for? Lithium is for gout. Yes, very good. Gout. Okay. Remember, when we did drugs, we did the drugs for your gout were colchicine and allopurinol. Those were the drugs that we use in for your gout. But when a person has gout, it is just the deposition of uric acid crystals. So it's important to avoid things that are high in sugar, like fruit juices, meat, whiskey, alcohol. All of that needs to be avoided. Everything except SED ions is positive. The only ions that are negative is going to be SED. For edema, we have your hyaluronate. Yes, you avoid all protein and everything needs to be avoided. Dhruvi, that's correct. Excessive protein, excessive meat, whiskey, alcohol, fruit juices need to be avoided for gout. Okay. Now, coming back from ions, we come back to the current. So everyone understood why, like now what is happening? Now, you are going to have that particular ion, you're going to give it with an electrode so that it repels and it goes into your body. That is the whole principle of iontophoresis, that whatever ion you want it to enter into your body, or that area where you want to give it with a similar charged electrode. Why with a similar charged electrode? So that they can repel and it can go inside the body. So if I'm using any of the SED ions, what is the electrode that I need to use? Should I use a cathode or should I use an anode? I use a cathode. Okay, so whenever I want to deliver my SED ions inside that particular area, you have to use a cathode. What about the other ions that we did, which were not the said ions? What is the electrode that we use with them? We're always going to use the anode for that, okay? So said ions, we always use the cathode. For said ions, we are always going to use the cathode. And for positive ions, we are always going to use the anode. Clear? Now, this is how iontophoresis works, okay? Whatever ion you want, put the same electrode and that will repel. But do you have just free ions that you can use, or ions always come in a solution? No, Dolly, that's a different thing. I will explain that when I come to it. Okay, just hold on. This is iontophoresis right now. Okay, so tell me that do you get free ions or you get it in solution? Ions are never free. They're always going to be in a solution. So like will repel. But what will happen to the, like let's say for an example, your calcium chloride. Okay, calcium chloride is a solution. Calcium is positive, chloride is negative. So calcium positive will repel from the anode and will go inside the body. What will the chloride do? Chloride also has to go somewhere, right? It will attract to the electrode because the opposite charges attract each other, right? So positive ions will attract on the negative electrode. Negative ions will attract on the positive electrode. Okay, now there is something that we need to know because these attractions cause reactions. Okay, so what do we want to know is if positive ions accumulate on the cathode, it causes an alkylic reaction. Okay, what do we mean by this? How do you remember this? Positive ions accumulate on a cathode. Now, think about a cat. Cat is a furious one, right? So if someone sits on the cat gets really angry. Same way, if positive ions go and sit on the cat, accumulate on the cathode, it's going to get furious and it's going to cause an alkylic reaction. Alkylic reaction can cause burns. Will you remember this? If positive ions sit on the cat, gets angry, causes an alkylic reaction, and that will cause burns. Same way, if negative ions accumulate on a anode, it will cause a acidic reaction. And what is an acidic reaction? It's not really dangerous. It just causes hardening of the skin or the skin thickening, hardening of skin. That is what an acidic reaction does. Okay, so you have two reactions. The main thing for iontophoresis we already did, right? That was repelling the ions and making sure you get the respective ion where it has to go. But what about the other things that are there? They also attract and they cause some reactions. So positive ions, when they sit on the cat, that is the cathode, it gets furious and it causes burns, alkylic reaction. When negative ions accumulate on the anode, it causes an acidic reaction that can cause skin hardening or thickening of the skin. Again, not that dangerous. So which one do you think is more dangerous? Is it the alkylic reaction or is it the acidic reaction? It's the alkylic reaction. So whenever you are using a cathode, you have to be more careful about burns, right? Whenever we are using a cathode, we have to be more careful about burns. Always remember that, okay? Now your next question here is, what do we understand by your current density? What is current density? The current that is given as per the surface area. So your whatever amplitude that we do divided by the surface area, that is called as a current density. What will happen if the current density is too high? Correct, it's going to cause burn. So current density is equal to your intensity divided by your surface area. So when the current density is too high, it can cause burns. So if to avoid that, what do we do? If you want to avoid burns, you want to avoid the current, like you want to prevent the current density from getting too high, what do we do? We can increase the surface area, right? Let's say you can increase the size. You can increase the size of the electrode that you are using. So you can increase the surface area. Okay, everyone clear? Now, whenever you give iontophoresis, we have to check in the first 3 to 5 minutes for any kind of skin irritation, any kind of redness, because it can lead to burn. So every 3 to 5 minutes you have to come and check for any kind of skin irritation or redness. If you are giving for more duration, it can increase the chances of burns. Okay, so any specific ratio? Okay, so wait for that. There's no specific ratio, because again it will depend on how much current is getting applied. Okay, but I have a question on it which I will give you after this. Okay, but before that I want to talk about dosage. Okay, I want to talk about the dosage. Okay, a dosage, how do we decide the dosage in your iontophoresis? This is another thing that I want you all to know. How do we decide the dosage in an iontophoresis? It always depends upon the intensity and the duration. So dosage is equal to intensity into the duration. That is your dosage. What is the normal intensity that we give with iontophoresis? Remember, it's always going to be 3 to 5 milliampere. That's your normal intensity. What is the duration? Normal duration is going to be 10 to 20 minutes. Okay, so duration could range from 10 to 20 minutes, and the intensity could range from 33 to 5 milliampere. Now the dosage also will range from 40 to 60 milliampere minute. Why? Because the dosage is a multiplication of your intensity and your duration. So what you have to do be able to identify the appropriate dosage, you have to do a permutation combination of these numbers. Okay. So let's assume if I tell you that a person has an intensity of 4, what should the duration be? You have to make sure that the intensity has to be between this, the duration has to be between this, and the dosage has to be this much. So your dosage should be either 40 to 60. So what should be your duration? Your duration should be 10 minutes. Okay, this is the best dosage that you could give in iontophoresis. So if you ever get an option for 4 milliampere for 10 minutes, it's going to be the best. But you can have other options also. Okay, always remember, if you are increasing the intensity, what will you do to the duration? Same thing like our ACSM. What do we do to the duration is going to decrease. Okay, so if you're increasing the intensity, the duration is going to decrease. So if I am going to increase the intensity, let's say I'm going to make the intensity 5, I should be somewhere between 8 to 10. Okay, now if I make the intensity 3, should I increase my duration or should I decrease my duration? So I can give a duration of 20 minutes. Can I give 1 milliampere current for 40 minutes? No. Why? Because whatever you choose, it has to be amongst this. The intensity should be between 3 to 5. Your duration should be between 10 to 20. And your dosage should be between 40 to 60. So just don't look at the dosage. You have to have an intensity that is between 3 to 5. You have to have a duration that is 10 to 20. What if will happen if you give a duration of 40? That acidic and that alkalic reaction, whatever is happening, is going to make the skin very bad, right? It's not going to keep the skin proper. So that is why it is essential that you follow this 3 to 5, 10 to 20, 40 to 60. What is the best? 4 milliampere for 10 minutes. You can do 3 milliampere for 20 minutes also. But whenever you are increasing the duration, always remember you have to check. You have to keep checking the skin for any redness, any irritation, because more we increase the duration, okay, it is going to cause an irritation to the skin. So you have to make sure that you check the skin. Okay, so the best dosage is going to be 4 to 10 minutes. Okay. Everyone clear with dosage? How do we avoid burns? So now how do we avoid burns in iontophoresis? So we already studied what type of current iontophoresis is: low voltage, low amplitude, low frequency. Another thing, does iontophoresis go only superficial or it goes deep also? What does it target? What does iontophoresis target? Superficial or only deep? it's going to target only superficial structures. So iontophoresis only goes for like 1 to 2 centimeters. That's it. Does not really target deep structures. Okay. So yes, so monophasic, low voltage, continuous current, target superficial structures. Okay, we did what is the current density? It is the intensity divided by your surface area. We have your cathode, anode. We did all the ions. We did the acidic. We did the alkalic reaction. Now another thing is, what would we do to avoid burns? What are the multiple things we could do to avoid burns? You can decrease the intensity. Okay, that's one. You can decrease the intensity. What else? You can increase the size of the electrode, because if you think that the current density is becoming too high, you can increase the size of the electrode. Okay, so that is something we can do. In any other electrical current modality, if you want the current to go slightly deeper and you don't want the current to have, you don't want the current to cause superficial burns, what do you do to the placement of the electrodes? You put them further away or you put them closer. You increase the distance. We should make sure we increase the distance between the electrodes so the current can go deeper. If your electrodes are too close, what happens? There is a lot of accumulation of the current superficially, and that can cause burns. Okay, so always the distance between the electrodes is very, very important. Okay, what is the minimum distance between the electrode that you should keep? What is the minimum distance we should keep between the electrodes? At least diameter of one of the electrode. Okay, so if this is my one electrode, okay, I just have to see the diameter of that, and at least that much distance is required between the two electrodes. Okay, whenever you're giving iontophoresis, make sure that you are cleaning the area. There is no resistance. Whatever electrode that you're giving is getting snugly fit. Okay, don't lie over the electrodes. Don't put pressure over the electrodes. You want the drug to get circulated properly. You want the medication to go properly. If you lie, you give pressure, what will happen? There will be poor circulation of the drug. You don't want that. So always make sure you clean the skin. There should be no resistance. Electrode should have a snug fit, and you are not giving any pressure over it, no poor circulation. You have to slowly increase the intensity, and your intensity range should be between 3 to 5. Okay, patient should not feel any pain. Patient should just feel a mild tingling, prickling kind of a sensation. That is your adequate thing that we should be doing with iontophoresis. Okay, everyone clear with iontophoresis? Let's see if I can paste this here. Okay, good. Tell me what is the answer to this? So Philip, this was what I was telling you. Your maximum current density is not any fixed ratio, but it should not exceed more than your intensity divided by your surface area. So what is the intensity divided by surface area here? It is 0.5 milliampere. Guys, do your math. 10 divided by 2 is not 0.2. 10 divided by 20 is not 0.2. It is half. Half is 0.5. Okay, it's not 0.2. Everyone good? Great. Now the other one, okay, now the other question is, I'm going to tell you that if you're using iontophoresis for a patient with lateral epicondylitis, okay, you are basically using iontophoresis to treat a patient with lateral epicondylitis to attain the same dosage as the previous session. If the physical therapist is increasing the intensity, how should he attain the same dosage? What should he do? Which parameter should he change? So I'm going to repeat again that you're giving lateral epicondylitis iontophoresis. You want to maintain the same dosage. You are increasing the intensity, but in order to maintain the same dosage, you have to reduce the duration. Perfect. What is the best duration? It's going to be 4 milliampere into 10 minutes. Okay, if I tell you the therapist wants to apply iontophoresis to an injury and wants around 40 milliampere current, okay, as a dosage, 40 milliampere minute. Okay, he's giving iontophoresis and the dosage that he wants is 40 milliampere minute. What is the best parameter? I mean, what is the best option you would pick? 4 milliampere for 10 minutes, 10 milliampere for 4 minutes, or 1 milliampere for 40 minutes? 4 milliampere for 10 minutes. So this is your question regarding your dosage. Questions regarding your ions are pretty straightforward. You just need to know what ion is for what. Remember, said ions are negative, rest everything is going to be positive. Anyone, any confusion with iontophoresis? Do you think you have it clear? That was your second modality done. Okay. Now, just your, can you please answer for the skin? The answer is 0.5, Divya. The answer is 0.5. It is 10 divided by 20. That is 0.5. Now, your indication for iontophoresis could be anything. Pain, wound, scar, myositis ossificans, calcium deposits, any time where you can use ions would be your indication. Your contraindication would be similar to your electrical stimulation, which is almost overlapping with ultrasound. But again, if you have pacemaker, you never ever give electrical stimulation. Cognitive issues, sensory issues, pacemaker, genital areas, all of that is the same. Okay. But what about anything additional with iontophoresis that we need to remember? Sarah, the question was giving 4 milliampere for 10 minutes is more adequate. Okay. And the lateral epicondylitis question was, if I am increasing the intensity, I have to reduce the duration. Okay. What is in any additional contraindication? Okay, what ions do we use for myositis ossificans? Your acetate. So that's going to be your acetate ion, calcium deposit. So that's going to be your acetate. Tell me any additional contraindication for iontophoresis apart from your other E-stim contraindications. Come on, guys, you know this. If you have any kind of drug allergy, you cannot use, right? If you have any particular drug allergy, you cannot use that particular ion. Okay. If you have sensitivity to direct current, if you have any, because you know iontophoresis is a direct current. If you have sensitivity to direct current, no. Impaired skin sensation, no. Yes, like a deep open wound, you can give it for open wounds. We are using zinc, right? We are using zinc. We are using fungal infections, bacterial infections. We are using iontophoresis for wounds. But any deep open wound, like completely deep open wound where it's not like healing is not the main thing, but it's like something that is very deep, and in that you cannot really use iontophoresis. Okay. So yes, blisters or where your skin is cut, you don't want to use iontophoresis. Okay, that may increase the irritability. Clear? Because we're doing iontophoresis, the next one that I want to talk about is your HVPC. That is your high voltage pulse galvanic current. Okay, your next one is going to be your HVPC. That's your high voltage pulse galvanic current. Now, what is the type of current? This is also monophasic. Is it pulsed or is it continuous? This is going to be pulsed. It's not continuous. Okay, is it high voltage, low voltage? It is high voltage. So this is your HVPC. What was iontophoresis? LVCC. Okay, LVCC was iontophoresis. HVPC is going to be your high voltage pulse galvanic current. Why do we use HVPC? HVPC is most importantly used in wounds. Okay, HVPC is commonly used in wounds. Does HVPC use ions? It does not use any ion. Okay, always remember HVPC does not use ion. If an ion is mentioned in your question, which means it is using iontophoresis, it's not using HVPC. So when there is no ion, that is basically your HVPC. Now, HVPC can be given for infected wounds and it can be given for uninfected wounds. Think about bacteria. Think about bacteria. What is bacteria? Bacteria are negative, right? You don't, anytime you see bacteria, you're going to be like, no, bacteria are negative. So to repel negative, you require a negative electrode. Which one is a negative electrode? Cathode or anode? Cathode. So whenever you have a bacterial infection, you are going to use a negative polarity. So the bacteria is going to get repelled and it's going to go inside the system and can get flushed out. Okay, from the wound, it's going to repel. So that's why bacterial infection is going to be your cathode. If they give you a culture-free wound, a wound that is non-infected or also called as a culture-free wound, then you are going to use anode. Okay, everyone clear? HVPC is a monophasic pulsed high voltage. Okay, now this is a monophasic, but it's pulsed. It's got a twin peak. So this is how an HVPC is going to look like. It has a twin peak, one peak, two peak, one peak, two peak, whereas iontophoresis look like this. HVPC looks like this with a twin peak. Okay, it is pulsed. All right. So now, if somebody tells you that, okay, for a bacterial infection, what do we use? We can use a cathode as a polarity with HVPC, and we can use anode for a culture-free wound or a non-infected wound. HVPC does not use ions. Now, how do you use HVPC? Do you put the electrode in the wound, or do you keep it outside the wound, proximal to the wound, distal to the wound? It's always going to be inside the wound. Is it directly going to be put inside the wound, or it's going to be wrapped in a saline gauze, or it's going to be placed on a wound bed that is covered with a saline gauze first? It's either going to be wrapped in a saline gauze or it's going to be placed over a wound bed that is covered with a saline gauze, but you are going to put it inside the wound and never outside the wound. Okay, now coming to the question that somebody had sent on the group, I think yesterday or day before, I think Chris had sent that question, said, why was B not correct? Even though you were using cathode, where was the electrode placed in that question? That electrode was placed proximal to the wound. Can that be a correct answer? No, which is why we chose a little better answer, like if the option was cathode placed in the wound, that would have been the best answer ideally, right? But the other option was anode with silver. So can I just assume my iontophoresis concept that, okay, silver is going to be positive, let me just use anode and repel the ion, right? You could use that concept. That's why you picked option A in that question and not option B, because your option B, it was placed proximal to the wound and not distal to the wound, and not inside the wound. Okay, so anytime you have a question on current that are used for wound healing, always remember your electrode has to be placed in the wound and not outside, proximal or distal to the wound. Make sense? So Pasha, your inactive electrode, your reference electrode could be placed anywhere. So every time you have an active electrode and an inactive electrode can be placed anywhere distal to the site. It can be placed under your neck, your shoulder, anywhere. Like how when you give treatment, when you're just using one electrode, your inactive can be placed anywhere. Does not matter. Okay, but whatever electrode you're using, that should be placed in the area in the wound. Okay. Now, whenever you're giving currents for wound healing, you can give monophasic currents. You can also give biphasic currents. Which ones are better? Are monophasic better or biphasic better? Monophasic are always preferred over biphasic for wound healing. Always remember that. That is why the two currents that we give for wound healing can be HVPC and LVCC, low voltage continuous current, or high voltage pulsed current are preferred for wound healing. Which are the biphasic current? Which are the biphasic currents? Your TENS. Your TENS is a biphasic current. So you can use biphasic also for wound healing, but which one has more effect in wound healing? Always pick, if you have an option for monophasic, always pick monophasic current as your better answer for wound healing. Got it? Perfect. Okay. So everyone clear with iontophoresis as well as HVPC, when to use what now? Great. Now the next one, which is, so TENS was your biphasic. Since we spoke about TENS, let's do TENS. TENS again, very important. LVCC is iontophoresis, so it has a lot of other functions, Sarah, like we did in the previous section. LVCC is your iontophoresis, so it can be used for multiple things, and wound healing is just one of it. Okay. All right. So TENS, what is TENS? Transcutaneous electrical nervous stimulation. Now TENS, what is the main job of TENS? Like what is TENS used in clinics for? The most important thing. Pain relief, always. Okay. TENS is always going to be used for your pain relief. If they give you a question that which is the best modality for pain relief, and they give you options where they're like where they give TENS, IFT, ultrasound, everything, you pick TENS because TENS is going to be something that is going to be given for pain management. Okay. Now ascending. Okay. Now with your TENS, you have mechanisms, ascending mechanism, descending mechanism, pain gate theory. I'm going to teach it to you in a very simple way so we can apply it to the different types of TENS. I know TENS can sometimes become very overwhelming. Okay, so I'm not going to be able to make you memorize the values, but in such a way we will do it so that you do not mess up the values. Okay, now pain gate theory. Okay, TENS always works by two things. It has an ascending mechanism, it has a descending mechanism. So the first thing we're going to talk is your pain gate theory. Have you all heard what is the pain gate theory? Pain gate theory is also called as the ascending mechanism of pain modulation. Okay, think about it. When you are stimulating, okay, so in your body you have the pain fibers. The fibers that carry pain are your A delta and C fibers. Okay, A delta and C fibers carry pain. These are your small diameter fibers. Okay, and A beta fibers, these are your big bad diameter fibers. They don't carry pain, they're just your mechanofibers, like your mechanoreceptors. Okay, so what happens? Stimulation of these mechanoreceptors. So when you give TENS, what are you stimulating? When you give TENS, you are stimulating the A beta mechanoreceptors. So these I told you are big diameter. So when someone is bigger and stronger than you, they can do the like they will like let's say you're having a race. If someone's bigger, fast, like if someone's bigger and stronger than you, then they can push. Like, okay, let me give you a better example. Race would not be a good example here, but let's say if you have to push a heavy object. Okay, if you have to push a heavy object, someone bigger and stronger to you is going to be able to push it first, right? Right. Yes. So now, same way, your A beta fiber, exactly, Philip. Thank you. So in your like your cars on an interstate. So if there are these big cars and big trucks, they're going to go there first. They're going to reach there first. They're almost blocking your path. Same way, once your A beta fibers get stimulated, they go and they block the gate for nobody else to enter. So they are blocking the A delta and C fibers to reach there. So what are you not perceiving if A delta and C fibers don't reach there? You're not really perceiving pain. Okay, so it's like your A beta fibers are your big fibers, your A delta fibers are your small fibers. So A delta and C are the ones that carry pain. A beta fibers are the ones that are mechanoreceptors. So what happens once you apply TENS? These A beta fibers get stimulated, they go and they block the gate, so your A delta fibers cannot access it. That's how you don't perceive pain. This is called as your pain gate theory or your ascending mechanism of pain. Can the trucks block the gate for like, can the trucks block the way for a very long time? No, eventually they have to give way, right? Same way, if something is working with the help of a pain gate theory, they cannot really block the pain for a very long time. That is why those pain relief effects are going to be a little bit temporary. Right? Good. Now, the second mechanism that we have is a descending mechanism. Okay, descending is the second mechanism of pain modulation. What happens here is, let's say you are pinching, you're giving like a big pinch, okay, like a very painful pinch. What is this? This is called as a noxious stimuli. What does the brain register? The brain registers this noxious stimuli. Now, our body has our own opioids. Body has own opioids which are called as endorphins and enkephalines. Okay, these are our body's own opioids that are basically getting released to reduce the pain. It's your body's mechanism. So when you give a noxious stimuli, so let's say if I'm giving a TENS that is very painful or a very noxious TENS, what does it stimulate in my brain? It stimulates the release of these endorphins and enkephalines. So my brain is going to start releasing these endorphins and enkephalines. What do these endorphins and enkephalines do? They block the release of substance P. Substance P means substance pain. So that's how pain is also not perceived. Okay, so what is a descending mechanism? Whenever you apply a noxious stimulus, your brain starts releasing endorphins and enkephalines. These endorphins and enkephalines block the release of substance P, that is pain, so they don't allow you to perceive pain. So that is called as a descending mechanism of pain modulation. But what was the difference? For the descending mechanism to get activated, what is necessary? For the descending mechanism to get activated, noxious stimulus is necessary. Perfect. Okay. So everyone understood pain gate theory pain gate theory is also called as an ascending mechanism where the A beta fibers get stimulated and they block the gate. That's how you're not perceiving pain. The other theory is called as a descending mechanism. In the descending mechanism, if you're providing a noxious stimuli, it causes the release of the endorphins and enkephalines, and endorphins and enkephalin block the release of the substance P, thereby reducing pain. Is that clear? Okay, now we go about doing the types of TENS, and hopefully this explanation is going to help you with the type of TENS, okay? Let's look at it. The first type of TENS is called as your conventional TENS, okay? This conventional TENS, I also call it, okay, it can also be called high TENS, okay? You can call it a high TENS. Or you can call it a sensory TENS. Why? Okay. Firstly, think about it. I'm calling my conventional TENS as a high TENS. That means something should be high. What is higher? My frequency is high. So anybody use like with conventional TENS, I'm not like going to make you memorize the exact numbers, but if you know the frequency is high, it's easier to memorize. So how much is the frequency for conventional TENS? How much is the frequency? I don't want you all to follow therapy yet. I want you all to follow Dr. Singh's class notes on TENS or your Cameroon. So how much is that? How much is your frequency in that? 30 to 150? Is that mentioned? Okay, I'm not really clear on the number, but 30 to 50 is going to be 30 to 150 is going to be a pulse per second. So means it's a high frequency. Okay, what about the duration? So if your frequency is increasing, what will happen to the pulse duration? It's going to be a low pulse duration. Now, what is a pulse duration also called? Pulse duration is called as a pulse width. That means for how wide the pulse is. Okay, that's called as a pulse duration. What is frequency also called? Frequency is always measured in the number of pulse per second. So frequency is always going to be pulse per second, PPS. And what is the pulse duration always going to be? In seconds, so that's going to be microseconds. Okay, so whenever you have high TENS, it's going to be high frequency and low pulse duration. Okay, high frequency, low pulse duration. That's why we call it high TENS. Conventional TENS, okay? Why do we call it sensory TENS? We call it sensory TENS because the amplitude that you give, when you give this TENS, the amplitude that you give is very comfortable and it just produces like a tingling, comfortable kind of sensation, does not cause any motor contraction. It just produces a comfortable sensation which activates the A beta fibers. Okay, that much sensation is enough to activate the A beta fibers. So that's why we call it the sensory TENS. Okay, so your first type of TENS is called as your conventional TENS, sensory TENS, high TENS. It has a high frequency, it has a low pulse duration. Okay, what is the amplitude? The amplitude is comfortable, tingling paresthesia kind of sensation. Okay, and it is continuous. What do you think? What mechanism is this going to activate? Ascending, descending? Very good. It's going to activate the pain gate theory. I mean, yeah, it's going to basically activate your pain gate theory, okay? Like your pain gate theory or the ascending mechanism of your pain gate mechanism, right? If it's going to activate the pain gate mechanism, it is going to block the gate. It's going to block the A delta and C fibers. That's how it's going to reduce the pain. So tell me, is this temporary or this is long-lasting effects? The effects are going to be temporary pretty much for 30 to 60 minutes. Okay, great. Everyone good with the first type of tense? Why do we use this tense? When do we use the conventional tense? Every time with acute conditions, because acute conditions, okay, whenever you have an acute condition, they really cannot, if you have an acute condition, they really cannot tolerate the pain. They need something that is very comfortable. So acute conditions, you definitely are going to give conventional tense. And you can also give for chronic conditions. I don't say you cannot give for chronic condition. You may give for chronic conditions. Some people cannot tolerate pain. You can give it. But for acute conditions, it's a must. You give conventional tense for acute conditions. Okay. The frequency, Sarah, you'll have to confirm in your class notes or your class readings. Okay. I'm not really sure because they got updated. So I'm not really sure on that. But if others are saying, that would be 30 to 150 pulse per second. Okay. Now the second one, okay, the second tense is called as your acupuncture tense or your low tense. So it's either called as the acupuncture tense or it's called as a low tense. So what does this low tell you? What is happening to the frequency now? Low. How much is the frequency? How low is the frequency? It's going to be 2 to 4 pulse per second. Good. And what about the duration? Pulse duration. The pulse duration is going to now be increased. Okay, your pulse duration is going to be high here. Your frequency is low, but your pulse duration is increased. Now, the type of stimulus that it's going to be more like a noxious stimulus. That means it's going to be a painful stimulus. So if it's more like a noxious or an acupuncture, what do you think is the amplitude? Amplitude is going to be high, strong, and produces a motor contraction. Do you agree it produces a motor contraction now? It's going to be high, it's going to be strong, and it's now going to produce a motor contraction. Perfect. Okay. So it's going to be high, strong, it's going to produce a motor contraction. Now, because this, what is the mechanism that it's going to activate? Is it going to activate the ascending mechanism or the descending mechanism? It's going to activate the descending mechanism. So now are the effects long lasting or are the effects temporary? The effects are more long lasting as compared to your conventional tense. Not forever. It's just going to be a few more minutes, like 10, 15 minutes more than your simple conventional tense. Is this clear? Now you have another mode, same in the acupuncture tense, the same low tense, you have a mode which is called as a burst mode. Okay, we have a mode which is called as a burst mode. Sometimes we call it as a burst mode kind of tense. Why the burst mode? Everything's similar to your acupuncture tense. Everything's similar. The only difference is now you are delivering more pulse per second. That means you're delivering higher frequency in small packets. So it's like a burst. It's like burst of mode. It's like how you say pulsed mode. Similarly, it's more burst. It's not continuous. So burst mode is a type of mode seen with acupuncture tense or low tense. When would you prefer burst tense? Burst tense, burst mode. You would prefer it when your continuous acupuncture tense is not tolerable. Sometimes you have chronic pain, but you cannot tolerate the intensity. It's very uncomfortable for you. The low tense acupuncture tense is very uncomfortable because it's continuous. So a burst mode can be something that is more comfortable as if you want to deliver acupuncture tense. Usually during labor, if they give tense, then they use the burst mode. Okay, so your acupuncture tense or the low tense was your frequency was low, pulse duration was high, Noxious stimulus activated the descending mechanism, long-lasting effect, and the amplitude was strong, producing a motor contraction. If your acupuncture tense is not really comfortable, patients can use the burst mode of your low tense. Good, clear? It's like a pulsed mode, you could say. All right, the third type of tense, okay? The third type of tense is called as your brief intense tense. What is this brief intense tense? Brief intense tense has high frequency and high pulse duration. So it has both high frequency as well as high pulse duration. Is it using ascending mechanism? Is it using descending mechanism? Is it using the pain gate mechanism or the descending? It's using the pain gate or the ascending mechanism. Okay, it uses the pain gate or the ascending. Now, look at the name. The name suggests it's a brief intense tense. That means you want to give the tense for a brief period of time. So when you're giving tense for a brief period of time to provide immediate short-term pain relief, that's the use of this brief intense tense. So that means, let's say you want immediate short-term pain relief, like you want pain relief for a brief period of time. That's when we use the brief tense. So for example, a patient is in acute pain and you want to perform mobilizations on them. What do you want pain relief for? You want pain relief for that 10 minutes that you can perform mobilizations on them. So prior to manual therapy, you can give them brief intense tense. Let's say you want to perform wound debridement. Okay, and it's very like, remember we said when we studied in integumentary debridement, your sharp debridement does not have any anesthesia. It requires us to pick a scalpel and just remove the necrotic tissue. If that's painful for the patient, you can give your brief intense tense before debridement, prior to debridement. So whenever you want to produce immediate short-term pain relief prior to certain procedures like soft tissue mobs, stretching, joint mobs, trigger point release, wound debridement, deep friction massage. So anytime you are giving the tense prior to the procedure, your keyword is prior to the procedure, you would pick brief intense tense. Make sense? So this was your third tense, which is your brief intense tense. High frequency, high pulse duration. Again, use the pain gate mechanism or the ascending mechanism. It is to produce short-term pain relief. So three most important ones that we did was conventional tense, which was your sensory tense or your high tense. Your acupuncture tense, which was your low tense, which was low frequency, high pulse duration. That was given mainly for chronic pain. Okay, acupuncture, we don't give it in acute. Why don't we give acupuncture in acute pain? Because they won't be able to tolerate the noxious stimuli. So you have to give it in chronic pain. And then if a person cannot tolerate the acupuncture tense, the burst mode can be beneficial. For pregnancy, when you during labor, you can prefer the burst mode. And your third type, that is your brief intense tense, high frequency, high pulse duration, it is your pain gate or your ascending. It's basically your pain gate or your ascending mechanism again, and it is given prior to performing any kind of procedure. There's one more tense, which is called as a hyperstimulation tense. Okay. There's one more tense which is called as a hyperstimulation tense. Giovanna, tense is not a modality that will be used mainly for your edema. No, tense is mainly for pain modulation. Sarah, yes, it's just a burst mode. The frequency pulse duration remains same as acupuncture tense. It's just the mode is a burst mode. Hyperstimulation tenses, look at the word hyperstimulation. So when someone's having chronic pain, okay, chronic trigger points, you can say when someone's having chronic trigger points, let's say you have a trapezius trigger point for a very long time, like that chronic trigger point has been bothering you for a very long time. That means a small area that is chronic. What can you do is you can put like a small electrode, like a small probe electrode there, and you can give a very high intensity for 30 to 60 seconds, like a very strong intensity. You just produce that very strong intensity for 30 to 60 seconds, okay? And that's it. That's what you give. Now, the parameters for a hyperstimulation tense are almost similar to your acupuncture tense. That means low frequency, and high pulse duration. So hyperstimulation TENS, when is it given? It's going to be when you have a small trigger point, small acupuncture point that is chronic. So what are you going to do? You're going to go and give a very strong intensity, noxious intensity for 30 to 60 seconds. So what mechanism it's going to activate? Ascending, descending? Descending, because it was a very sharp, like a noxious stimulus, and the parameters were same as your acupuncture TENS. So the effects are going to be slightly more long lasting. So these are your 4 types of TENS: conventional TENS, acupuncture TENS, brief intense TENS, and your hyperstimulation TENS. Is that clear? Now, whenever you give TENS to a person, okay, within the machine itself, so that your nerves don't get adapted, it's basically it keeps, like, your parameters keep changing, like by 10% every second, little by 10% every second, your parameters keep changing. Why do they keep changing? They keep changing to prevent the neural adaptation. Like, you don't want to experience the same thing for 10-20 minutes, right? You're going to develop tolerance to it. So that's called as modulation, TENS modulation. It's not like a specific mode or anything. Any kind of TENS that you take and you're taking it for 30 to 40 minutes, it basically modulates. That means it changes every, like, 10% every second, so that you don't get adapted to that particular TENS. Okay. Yes, hyperstimulation TENS is identically similar to your acupuncture TENS or your low TENS. Parameters are also similar. The only difference is, for hyperstimulation TENS, it's a small chronic trigger point or acupuncture point, and you're not giving it for 15-20 minutes like your acupuncture TENS. You're giving it only for 30 to 60 seconds, a very strong amplitude for 30 to 60 seconds. That's the difference between your acupuncture and your hyperstimulation TENS. Clear? Where should you place the TENS electrode? Where do we usually place the electrode? The TENS electrode, where do we usually place it? You could place it along the nerve root. You could place it along the dermatomes, myotome. You could place it proximal and distal to the incision site. You could place it in the location of the pain, painful area, incision site, everything. So TENS can basically be placed everywhere. There's no particular indication. Wherever you feel it's the appropriate need of it. Let's say if you have herpes zoster, you're going to put it in a dermatomal pattern. If you have a surgical incision, you're going to put it like parallel or proximal distal to the incision. If you have 1 point pain, you're going to put it there. So basically, TENS can be put anywhere. And the main goal of TENS is acute and chronic pain modulation. Always remember, best modality for pain is going to be your TENS. Contraindication, same like any other electrical stimulation: pacemaker, neck, face, epilepsy, cancer, genital areas, eyes, and all of that. Okay, so that's going to be your eyes, larynx, pharynx, carotid sinus, all the same contraindications like your any other electrical stimulation. Can you repeat the position of the TENS during labor? So during the first 2 stages of labor, like initial labor, the TENS is placed in the lumbar area. Later on, in the last stage of labor, they put it near the S3, S4, or the genital area. Okay. Now, just a common thing here. Just a question here. If you think that let's say your intensity, okay, if the patient is feeling too much intensity, but there is no contraction, what do you think is the problem? What parameter should you work at? Patient is feeling a lot of intensity, but you are not able to see the contraction. You should work with the pulse duration. Increase the pulse, that means the width of that pulse, like the pulse duration may be really low, which is why you are not able to see that contraction. So that is when you basically increase the pulse duration. But let's say if I tell it in a different way, that you are you have given electrical stimulation to a patient, okay, and the patient feels that the intense, like basically if you want to maintain the okay, let's say if the patient feels like the intensity is fine, okay, but still the intensity is not too high, but still the patient is feeling the current too strong, then what do you reduce? Intensity is fine, intensity is already too low, still the patient is feeling the current too strong. That means what do you reduce? Again, pulse duration. Like I told you, pulse duration is the width of the current. So that means if the width is more, that means your contraction is going to be more stronger. If your width is less, the contraction is going to be more weaker. So if your width is too much, okay, if you have increased pulse duration, and if the contraction is too strong, it can get uncomfortable at times, right? So if your intensity is fine, but the patient still feels uncomfortable, then what should you reduce? You should reduce your pulse duration. And same way, in a different way, if your intensity is high, but still the patient cannot feel the contraction, that means your pulse duration is too less, which is why you're not able to feel the contraction and you'll have to increase the pulse duration. Does it make sense? Okay, so remember, how greater the pulse durations, your contraction is going to be more visible. Lesser the pulse duration, your contraction is not going to be very visible. So if the pulse duration is too high, it can get uncomfortable. Okay, or if the pulse duration is too low, you won't be able to see the contraction. Okay, let's do some questions on this. Tense, 1 minute. Let's first do this question. This is a little tricky question, but I like it. Oh, wait, why is it doing 1 minute? Not this one. Trying to copy it. Why? Oh, sorry. Just a second. Okay, I got it. Okay, let's do this question. Pulse duration is the same as pulse width, Sarah. Think about this question. Okay, it's a little tricky one. Think about it, okay? Think about it. Read the question. Okay. All right. It's okay if you don't know. This is a tricky question. Okay. So it's fine. Now, here it says that a patient is applying an electrotherapeutic modality to a 2-year history of lumbosacral dysfunction and low back pain. What does this tell you? This is a chronic problem. Okay. Based on a chronic problem, what kind of TENS will you give? Will you give, based on this chronic problem, what kind of TENS do we give? Do we give like a sensor? Do we give a high TENS? Do we give a low TENS? What kind of TENS do we give? Low TENS, right? So is low a motor one or is high a motor one? Low. What is high? It's a sensory. So what options can I eliminate here? You can eliminate sensory. You can eliminate sensory. Now you're stuck between 2 and 4. Now when there's a patient, who is a 2-year history of lumbosacral dysfunction, low back pain, okay, which is the most appropriate for this patient. So now when the patient comes to the clinic, do you want to prefer like in that time to give TENS to the patient, or because it's chronic pain, you're going to first work with postural mechanics, you're going to work with all your mobilization, manipulation exercises, and you can just give them a portable TENS at home? What would you prefer? Portable, because it's a chronic pain. It's not acute that you need to give him immediate modality first. That is why your option 4 is your correct one. Okay, Beatrice, the question says portable or clinic based. Okay, we pick portable because the patient has a chronic pain. If they have a chronic pain in the clinic, you're focused on making them do more postural, more exercises. So you focus on just giving them a TENS unit at home. At home TENS unit is called as a portable TENS unit. Okay, you guys are going to do great. Don't worry. If the patient feels uncomfortable, Devanshi, you can reduce the pulse duration. And when the patient does not feel any contraction, even though intensity is appropriate, then you'll have to increase the pulse duration. Okay. Motor level Beatrice means motor stimulation. If we go back to our type of TENS, your acupuncture TENS was the one which was motor, and your conventional TENS was the one which was sensory. So conventional you are giving when you have an acute pain, sensory, but when you have a chronic pain, you cannot give acupuncture, you cannot give conventional. You're going to typically give a acupuncture TENS, which is a motor level stimulation. Okay. All right. Okay. Now, yes, acupuncture TENS, low TENS is going to be chronic. Okay. I'm going to send you guys one or two questions from therapy ed. Okay. They are, let's do those. Okay. They are from therapy ed, but I'm going to send them on the group. Let's solve them. Okay. So first, I want you to solve the question which says patient presents with acute L5 radiculopathy. Please read the question properly. Don't miss out the keywords. Okay. The question, what does the question say? Acute L5 radiculopathy, pain is rated at 9 out of 10. If you stop reading here, you're going to put conventional TENS. But if you read further, therapist decides to apply TENS prior to manual therapy, then your answer is going to be brief intense TENS. Good job. Answer should be 2, not 4, because it says prior to manual therapy. Okay, next one. Let's do the next one. Good job. They're telling you that the therapist is applying pulse current to the vastus medialis to improve patella tracking. The patient complains that the current is too strong, okay, and too uncomfortable. Okay, to make the current more tolerable to the patient yet maintain a good therapeutic effect. So that means the current is too strong, but it's uncomfortable. So to make the current more tolerable, there is no option for decreasing the intensity, right? So what do we decrease? We decrease the pulse duration, because I told you if the pulse duration or the pulse width is too much, it's going to be more uncomfortable. Beatrice, the question number one here, the question number one that you're saying, if you look at our type of tense, when we did brief intense tense, we said that brief intense tense is a tense that is given prior to performing any procedure, prior to performing debridement, prior to performing manual therapy, so that the patient can tolerate that procedure, so that the patient can tolerate it. In this question, your question number one, it says that the patient is giving tense to modulate pain prior to manual therapy. That's your keyword. And then you are going to be giving brief intense tense. Okay. Good job. Everyone feels good about tense? Great. Now we're going to do the parameters for some other parameters for electrical stimulation, because electrical stimulation can be used for muscle strengthening, can be used for edema, can be used for muscle spasticity. Okay, so it's going to be used for multiple things. So let's do the parameters for each one of them. Okay, I sent you a table which is from Cameroon. I'm going to help you break down that table, and we're going to do it in a way that you will remember. Okay, so that's your E-stim. Okay, now all of these are types of E-stims, but this is the E-stim. Like these are the parameters that we're going to use for stretching, for strengthening, for muscle spasm. So we're going to discuss those. Okay, whenever the question says muscle strengthening, okay, whenever the question says muscle strengthening or muscle re-education, okay, muscle strengthening, muscle re-education, or a patient has muscle weakness, that indicates that you are going to use the strengthening parameters, right? Muscle atrophy, muscle weakness, muscle re-education, muscle strengthening. That means you're going to use these parameters where a muscle is weak and you need to strengthen it, okay? Couple of things you need to remember, okay? It's easy to memorize it. It's not too difficult. And these ones are really important, which is why I'm going to write them down here too, because they do ask these parameters in the exam. Okay, first is your pulse frequency. I would say always remember it 35 to your 80 pulse per second. Okay, it's going to be 35 to 80 pulse per second. Okay, others are going to be 35 to 50, but 35 to 80 is going to be for your muscle strengthening and your muscle re-education. So that's your pulse frequency. Your pulse duration is going to be 150 to 200 microseconds for small muscles. Okay, it's going to be 150 to 200 microseconds for small muscles, and it's going to be 200 to 350 microseconds for your big muscles. Okay, 200 to 350 microseconds for your big muscles. All right, so your muscle strengthening, your muscle re-education, your pulse frequency is going to be 35 to 50. Pulse duration is going to be 150 to 200 for small muscles and 200 to 350 for big muscles. We have to remember these two parameters. It's going to come repeated for all of them. So it's, once you know just this much, it's fine. Everybody does not have different parameters to memorize. Okay. Now, which is the next thing that we need? We require a duty cycle. Now, what is a duty cycle that we use for muscle strengthening? What is a duty cycle that we use for muscle strengthening? A duty cycle that we use for muscle strengthening is going to be 1 to 5. Very good. So we start with 1 to 5. We can go on to 1 to 4. Okay, we can do 1 to 4. We can do 1 to 3. But remember, you will not go below 1 to 3. So you don't want to go below 1 to 3. If you go below 1 to 3, it's no longer going to help with strengthening because the muscle is going to start getting fatigued. 1 to 1 is almost like 1 second on, 1 second off. 1 to 2 is 1 second on, 2 seconds off, right? So it can cause fatigue. So always remember, for muscle strengthening, muscle re-education, muscle atrophy, regaining strength, anywhere, whatever words they use, your duty cycle will always be 20%. You can have like 1 to 3, 1 to 4, 1 to 5, but never less than 1 to 3. Okay, that's what your duty cycle is going to be. Now there's another thing which is called as a ramp. What is a ramp? A ramp in an electrical current is when the current slowly goes up, it stays up for a while, and then it comes down. So this is a ramp. Why do we need a ramp? Why do we need the current to slowly go up, stay there, maintain it, and come down? Why do we need this ramp? So that your contraction is good, right? If you're doing for muscle strengthening, muscle contraction, can you just, if you're doing for muscle re-education, can you just do something like this? No, you need a ramp that is more effective, like you can see the contraction. Yes, it helps. So your ramp is going to be at least 2 seconds. Okay, at least 2 seconds is going to be your ramp. Ideal ramp will be 4 seconds. Okay, anything between 1 to 4, but I would recommend at least 2 because our textbooks say that. Okay, so 2 seconds. But ideal scenarios, your ramp should be around 4 seconds. Okay. Now, if you have, let's say, if you have a ramp that is in your exams, if you have a ramp that says 8 seconds and you have a ramp that says 4 seconds, which one will you pick? You're going to pick a ramp with 4 seconds. Perfect. Okay. So that is what your muscle strengthening, muscle re-education. So everyone clear with these parameters? Your muscles, your pulse frequency 35 to 80, pulse duration 150 to 200, 200 to 350 for your big muscles. Duty cycle will always be greater than 1 to 3, and your ramp will at least be 2 seconds. Ideal scenarios, your ramp should always be 2 to 4 seconds. Ideal scenarios. At least for your muscle strengthening, your ramp should be 2 to 4 seconds. Okay. Now, the next thing is, does anybody know what MVIC is? MVIC is something that we're going to use to identify the amplitude. So what is the MVIC? Yes, maximal voluntary isometric contraction. It's a contraction that you maximum voluntary isometric contraction that you get. That is your MVIC. Now, when you strengthen, you have to strengthen them at a percentage of their maximum MVIC. You have to strengthen them at a percentage of their MVIC. Correct? So, how much is the percentage of the MVIC that we are going to use for strengthening? At least greater than 50% for your non-injured muscle. Okay, greater than 50% for your non-injured muscle. That is very important. Now, what do I mean by injured muscle? Okay, now understand this. Injured muscle is something that has got an injury. Okay, or let's say after a rotator cuff repair, after a ACL surgery, those are injured muscle. If your muscle is not injured, you cannot ever strengthen at an intensity that is less than 50% of their MVIC. Greater the MVIC, greater is going to be the strengthening. So if you have an option to pick, but what percentage would you want of MVIC would you want to strengthen a person with so and so, like for muscle strengthening of so and so muscle? Higher, like 60%, 70%, anything higher. Higher is better to strengthen the patient. Okay. For a person where you have an injured muscle, okay, it does not say that high is bad, but sometimes if the muscle is severely injured, you won't be able to reach that high, right? So then it is acceptable to go below 50%, like 10%, 20%. It's acceptable to go below 50% only when the muscle is injured. But let's say if an injured muscle can also tolerate greater than 50, can you go there? Yes, there was a question on it somewhere that had an injured muscle, but there was an option for greater than 60%, which was right. So if the patient can tolerate greater than 50%, always higher MVIC is okay. But for a non-injured muscle, you can never go less than 50%. For an injured muscle, if they cannot tolerate high, you can go as low as 10%, 20%. This is the intensity at what you are going to work. So intensity is a percentage of the maximum voluntary isometric contraction. No, it does not lead to tissue destruction. It can help with the muscle strengthening. Okay, so when the MVIC is higher, duty cycle decreases. Not necessary. You can give the same rest period. You can give the same. You can give more rest and less work. That's fine. Duty cycle is on and off. So when you're on, you do the high work. For when you're off, you take the rest. So it does not really have to matter with the duty cycle. Okay, is that clear? Are all the parameters for muscle strengthening, muscle re-education clear? Yes, for large and small muscle, it's the same. Only the pulse duration varies for large and small muscles. Okay, so everyone understood pulse frequency, pulse duration, your duty cycle, your ramp, and your MVIC. These were the 5 parameters that we need to know. Now we move on to the condition. Now, other condition could be muscle spasticity. Let's say muscle spasm, or let's say muscle spasticity. What do we need in muscle spasm and muscle spasticity? We need to relax the muscle. Okay, we want to fatigue the muscle. Now we want to relax the muscle. So your pulse frequency is going to be the same. Okay, but instead of 35 to 80 in the textbook, say it's 35 to 50. Pulse duration is the same, 100 to 150, 200 to 350. That's also going to remain the same. What is going to change is the duty cycle. You don't need any intensity here because again, it's just it's spasticity. You're not really strengthening. But what you need to focus here is the duty cycle. What is the duty cycle that we give for muscle spasm or muscle spasticity? What is the duty cycle that we give for muscle spasm or muscle spasticity? Your duty cycle here is going to be either continuous, either 1 to 1 or 1 to 2. Okay, so that means anything less than 1 to 3. So 1 to 1, 1 to 2, continuous, that's going to be your duty cycle. Okay, is that clear? So muscle spasm, muscle spasticity, you have the same parameter, pulse frequency, pulse duration. What changes is your duty cycle. So if your biceps is spastic, what do? You give a continuous current, or you can give 1 to 1, 1 to 2, and you have to fatigue the muscle, because when the muscle fatigues, it is basically more relaxed and you can stretch it. Okay, so for muscle spasm, muscle spasticity, we want to fatigue the muscle. What will the ramp be? If you want to fatigue the muscle, you don't really need a high ramp. There's no need, right? You just want to fatigue. So a ramp of 1 second, 2 seconds is also okay. Okay, ramp of 1 second, 2 seconds is also okay, because you really do not need a ramp to kind of fatigue that particular muscle, right? Agreed? This is one way. Okay, this is called as autogenic inhibition. Okay, when you're fatiguing your own muscle, when you're fatiguing the agonist, it's called as autogenic inhibition. Why autogenic inhibition? Because the biceps is spastic, you're fatiguing the biceps, okay, and that is basically inhibiting the biceps, right? So it's called as autogenic inhibition. But there's something which is called as reciprocal inhibition. Okay, how do you do the reciprocal inhibition? Instead of fatiguing the biceps, what would you do now? Instead of fatiguing the biceps, in order to reduce the muscle spasticity, what would you do? You will activate the triceps, because activating the triceps will also cause in reduction of muscle spasm spasticity of your biceps. Agreed? So how do you activate the triceps? Do you use the spasticity parameters, or do you use the muscle weakness parameters that we did earlier? If you want to activate the triceps, you have to use the muscle weakness parameters. That means we go back to pulse frequency, pulse duration, duty cycle being greater than 1 to 3. So 1 to 4, 1 to 5, and ramp at least 2 seconds, right? Because now you are not fatiguing the biceps, but you are activating the triceps. in order to reduce the spasticity of the biceps. So this one is called as to reduce muscle spasm, muscle spasticity. There are two ways. You either go the autogenic inhibition way or you go the reciprocal inhibition way. Autogenic inhibition means fatiguing the same muscle. So when you're fatiguing the biceps, you are giving 1 to 1, 1 to 3, 1 to 1, 1 to 2, and continuous current. No, it's just the same. There's no one efficient over the other. It depends on you or what the patient prefers. Okay, you could do both the methods. So you either do autogenic inhibition by fatiguing the biceps, or you do reciprocal inhibition by activating the triceps using the muscle re-education parameters. Good. So here we are done with muscle re-education, muscle strengthening, muscle spasm reduction, spasticity. What you're left with your edema. If you have edema, again, nothing changes. Pulse frequency remains 35 to 80. Pulse duration remains 150 to 200, 200 to 350, same. Okay. Amplitude, it is also not needed to be too high. Basically to get edema, do you need a very high amplitude? No, you just need to see the visible contraction. But the most important, what is different again in edema is the duty cycle. What is the duty cycle that we need with edema? 1 to 1. Why 1 to 1? Equal contraction, equal relaxation. Equal contraction, what is this causing? Equal contraction, relaxation is causing the pumping effect. Okay, equal contraction, relaxation is causing the pumping effect, and it's going to help in improving the circulation, pushing the fluid back. So that is why edema, everything else remains the same. It's just that you are going to give a muscle, your duty cycle is going to be equal contraction, equal relaxation, 1 to 1. Again, you don't really need a ramp with edema, right? You don't need to see that great contraction up there. Everyone clear with these parameters that we use with electrical stimulation for muscle strengthening, muscle re-education, muscle spasm reduction, and edema? Okay, whenever you give electrical stimulation, we could use there are different ways how we place the electrodes. Okay, this again may not come in your exam, but I just want you all to know what is this technique. Okay, muscle re-education, it's the same as muscle strengthening, Riddhi. Muscle re-education is going to be same as your muscle strengthening when it comes to the duty cycle. Okay, now I was telling you about the electrode placement. There are multiple ways how we can place electrode depending on what is the effect that we want. So you have monophasic placement of electrode. We have not phasic, sorry, monopolar, unipolar, rather than monopolar, unipolar, bipolar electrode placement, and your quadrupolar electrode placement. What is unipolar? The one we were discussing with iontophoresis or anything. When you just have one electrode that needs to be at the site, okay, when you just have one channel that needs to be at the site, and the other electrode is a reference electrode which is away from that body part, that's called as a unipolar placement of the electrode. So let's say you have like these two channels. Okay, 1 minute. You have channel 1, you have channel 2. When channel 1 is exactly in the area where it is supposed to be, and the electrode in the channel 2 is somewhere far away, which is a reference electrode, that's called as a unipolar placement of electrode. Okay. When you have a bipolar means both your channels, channel 1 and channel 2, they both are going to be close to each other. So let's say if I want to stimulate like my biceps and I put one electrode here, one electrode here, both are there at that place. That's going to be called as a bipolar placement of the electrode. And quadrupolar is like IFT, right? It's going to be in like a 4-position way, like a quadrupolar. This is going to be like a quadrupolar placement of the electrode. Okay, clear? Everyone good? Unipolar, bipolar, quadrupolar kind of electrode. Okay. Again, your contraindications for electrical stimulation, same. Anything like any kind of cancer or anything, it's going to be same. Yes, there are 2 different channels for unipolar. That is correct. Okay, it's going to be channel 1, channel 2. It's going to be 2 different. Okay, yes, pacemaker or during pregnancy, open wounds, and all of that you are going to avoid electrical stimulation. Okay. Again, electrical stimulation for pregnancy is more like a precaution. They don't, I mean, it depends. Okay. Yes. Now, if we already discussed this, if you want the current to go deeper, what do? If you want the current to go deeper, you're going to increase the distance between your electrodes. What is the minimum distance between the electrodes? The minimum distance between the electrode is at least a diameter of one of the electrodes, right? Okay. Now, since we're here itself, okay, let's talk about your EMG biofeedback. Okay, we did not speak about, we can talk about EMG biofeedback. I think somebody had asked a question the other day on the group. Yes, whenever you want the current to go deeper, you have to increase the distance between the electrodes. And the minimum distance that is between the electrode should at least be diameter of one of the electrodes. Okay, now your EMG biofeedback. Why do we use EMG biofeedback? We use an EMG biofeedback. It's a machine that, I mean, it's your whatever is getting stimulated, your muscle. The impulse can be seen on the screen. You can hear the contraction, everything. So it's like a biofeedback for us to see what we are doing. Are we contracting enough? Are we relaxing? So it's basically like a visual and auditory kind of feedback that you receive. Now, this is very important. This is very beneficial when you want to strengthen a muscle or when you want to relax a muscle. Okay, I have a mnemonic that I usually like. This is how I remember always. My mnemonic is she loves and fancies him. Okay, what does this mnemonic indicate? She loves and fancies him. So the S here. Okay, the S here stands for spasticity. So spasticity or spasm. So whenever your muscle is in spasm or hyperactive or overactive muscle or spasticity, your sensitivity is going to be loves. So what is your sensitivity going to be? Low sensitivity, right? So whenever it is muscle spasm, low sensitivity. How are the electrodes going to be placed with muscle spasm? Closely spaced electrode. Very good. Now the other is and fancies him. The F stands for flaccidity. You can also say flaccidity and far, FF, flaccidity, also far placement. So the electrodes are going to be far placed. What is going to happen to the sensitivity? Him, H. So it's going to be high sensitivity. So this is the first thing you want to remember in your EMG biofeedback. Whenever you have an EMG biofeedback and they ask you the initial parameters for muscle spasm, it's always going to be close spaced and low sensitivity. If they ask you the initial parameters for flaccidity, it's always going to be far spaced and it's going to be high sensitivity. Okay. Now this is provided if your muscle is adequate size. What if you're using a muscle that is very small? Let's say small as in they mention in the question that the muscle is very small, or they give you like one small muscle from the extensor of your hand, or they give you one small muscle from your feet. Then no matter whether it is spasticity or flaccidity, your electrodes will be closely spaced, because if they are further spaced, they're not really affecting that muscle, right? They're affecting other muscles around it. So whether it is spasm or whether it is flaccidity or weakness, flaccidity is similar to your weakness. So whether it is muscle weakness or whether it is muscle spasm, but the question mentions a small muscle, or they tell you like they actually use the word small muscle, or they give you like one single muscle of your extensor group or anything, that means that spasm will still have low sensitivity with closely spaced electrodes. Weakness will still have high sensitivity, but also with closely spaced electrodes. Is that clear? If you have a small muscle, irrespective of spasm and flaccidity, you still will have close placement of the electrode. But otherwise, this stays. She loves and fancies him stays as your initial parameter. Okay? Later stage, that's my next thing. Give me a second. Okay, this is what we need to know initially. If your question says progress, okay, now if the question says that the patient has been coming for trapezius hypertrophy for the last 2 weeks, the patient has shown significant progress. What are the EMG biofeedback parameters that you're going to give. So that means if the patient was coming from trapezius hypertrophy, what were the initial parameters? If he had trapezius hypertrophy, what were his initial parameters? Come on, tell me. Trapezius hypertrophy, that means it was going to be low sensitivity and it was going to be your closely spaced electrode. Perfect, right? So now they're telling you that the patient is 50% better or 15% or 20% or 25%. They just say the patient is better. What will you do? You flip it. You will start increasing the space. So you'll make it far spaced electrodes and high sensitivity. Okay, just flip the parameter. Same way, if they tell you patient is coming for quadriceps strengthening, the patient has been coming for 2 weeks, 3 weeks, and is showing good progress. What are your parameters that you would do? Flip it. You will start reducing the sensitivity and you will start keeping the electrodes closely spaced. Make sense? You flip the parameters when they are your progression parameters. So your she loves and fancies him are initial parameters. Progression parameters are just flipping it. Okay, make sense? Everyone clear? Are you guys with me? Come on, give me a few more minutes. We're almost done. Okay, we're almost done. All right. Now, when you are in, you flip both together. Okay, great. Alive and well. That's what I want to hear. Okay. For larger muscles, it will be far placed. Divya, for your initial parameters, yes. For your progression parameters, whatever is your initial parameter, you flip that to your progression parameters. Okay. Now, your IFT again is not asked a lot in your exam, but I just want you all to have a base of IFT. What type of current is IFT? It's a polyphasic current, okay? IFT is like a polyphasic. The two polyphasic currents like TENS was biphasic. IFT and Russian currents are polyphasic. That means they have a lot of phases, okay? IFT and Russian currents are polyphasic. What is IFT? IFT is basically when you have two waves which are medium frequency, okay? When you have two waves that are medium frequency waves, okay? When you have two waves that are medium frequency waves, okay, and they interfere with each other to form a low frequency wave. That is called as a IFT. So it's an interferential current. So they interfere. So let's say this was a 3000 megahertz of like megahertz current, and this was a 2000 megahertz current. What happens? They interfere. So they form a current which is now 1000 megahertz. Okay, yeah. So basically two medium frequency current, they overlap to form a low frequency current. That is what an IFT is. What are the use of IFT? IFT also reduces pain. It can be used to increase the muscle strength and it can also be used to increase the circulation in that area. Now, IFT placement now depends on you have like a bipolar placement or you have a quadripolar placement, okay, in IFT. Now, what is the bipolar one called? It's called as a pre-modulated. Okay, it's called as pre-modulated IFT. Why pre-modulated IFT? Because usually what is done in IFT, you have 4 electrodes like a clover leaf. Okay, like how we have a clover leaf pattern. You have 4 electrodes and they interfere here. They interfere in the center, right? That is IFT. But if you have a very small area to treat, the interference already happens in the machine. It's called as pre-modulated. Interference happens in the machine and you just use a bipolar placement of electrode and you work on the small area. So if you're giving IFT to a small area, then you can use a pre-mod. That's your pre-modulated, which is given for smaller and superficial areas. If you want to give for a larger area, like a low back, deeper, what will you use? You will use your quadripolar technique. Okay, this is your quadripolar technique that is used for bigger and larger areas. There is something which is also called as a quadripolar with vector. Now, quadripolar with vector is something which is like extra large and deeper areas. So it's nothing, it's just that it's basically having a vector effect. The field is like spinning throughout. So that's called as a quadripolar with vector, but I've never seen questions on that, but just remember that much, that if it's a larger area, use like your normal clover leaf quadripolar kind of a pattern. The area of interference is where you're going to get pain relief. For pre-mod, it's a smaller area, superficial tissues. That's when you're going to use a pre-modulated IFT. IFT is also used for muscle strengthening, your pain modulation, as well as your improving circulation. Same way, your Russian currents are also polyphasic currents. Okay, your Russian currents being polyphasic currents are also used for muscle strengthening. Again, I haven't really seen Russian currents in your exam either, which is why I don't want to go into depth of it. Okay, good. Everyone clear? Okay, just a little light topic. Tell me, when do we use a tilt table? When can you use a tilt table? Tilt table can be used after any brain injury, spinal cord injury, for postural drainage, for neuro to basically help you orient to the surrounding, for people with orthostatic hypertension, correct, for orientation, or when you want to basically put a, like for people who you want to put a stretch on the knee flexors, plantar flexors, you want to have them stand, anything you can use your tilt table, right? Now, whenever you're using a tilt table, of course, the patient is laying down. There are straps at the axilla, pelvis, everywhere. Make sure that you are secure, right? Yes, for physiological standing, for proprioception, excellent. When you start picking them up for like, there is a high chance of getting orthostatic hypotension. So you have to be very, very careful. So what do? You gradually increase it. You gradually increase to 30 degrees, 45 degrees, 60 degrees, 80, 85. That's how you are going to slowly increase. At each position, are you just going to like look at it and just move on? Or are you going to hold at each position? You're going to hold at each position. You're going to measure the blood pressure at each position. You're going to look for signs like cyanosis, pupillary dilation, any bluing of the fingernails, lips, or anything. You're going to identify, are there any signs like that? You're going to check the blood pressure. If there is a drop in blood pressure by 10 mmHg, what do? Do you put the patient back to flat position, or you keep monitoring? 10 mmHg drop. You keep monitoring, because 10 is not like it's going to happen. If you are bringing the patient up from supine to standing, 10 is going to happen. So you keep monitoring. If there is a drop more than 20 and you start seeing signs, then you are going to put the patient down to the flat position. Correct. Okay. So to avoid orthostatic hypotension, what do we do? I mean, as an extra caution, what can we do? You can wear abdominal binders. You can wear compression stockings. So you can wear abdominal binders, you can wear compression stocking in order to assist with to prevent the orthostatic hypotension. Yes, this is the systolic blood pressure, not the diastolic blood pressure. Okay. We no longer have SWD in your syllabus. Okay. We no longer have shortwave diathermy in your syllabus. So that is good. Let's talk about traction. What do we know about traction? Traction is two. You have your cervical traction. You have your lumbar traction. Couple of things that are important in traction. Okay, couple of things that are important in traction. One thing is your position. One thing is the weight. Okay, we have your position. We have your weight of the traction that we give. The other is the degree. Okay, the position, the degree of flexion that is needed. Okay, so let's start with your cervical traction. Okay. With cervical traction, what position do we prefer? Preferably supine position. Okay, preferably supine position. Sitting can be done, but I mean, preferably all those traction units now, they have your supine position. Okay. Yes. Now, with supine position, how much weight do we prefer for cervical traction? Always 7% of the body weight can exceed up to 7 to 10% of your body weight. Initially, you always choose 7%. Now, in your exam, they won't directly put 7%. They will give you the weight of the person and you have to calculate. So multiply it by 0.7 to get the weight. Okay. It is in your exam, they will actually give you the weight of the person and they will tell you how much percentage, I mean, what is the weight that you should give for traction. So no 7 to 10% and be ready to do the math there. Okay, so 7 to 10% of the body weight. Okay, now position, we said supine. Now, when you are giving cervical traction, should the neck be extended or should the neck be slightly flexed? No, you cannot have a calculator, Anushka. Your neck should be slightly flexed. Why? To eliminate the lordosis. What will happen if your neck is extended? Your joint will be closed. There will be closing of the joint, right? There's going to be closing of the joint when your neck is extended. So if there is closing of the joint, it's not going to help, right? You want to open it. So you're going to cause some flexion. Now, based on as you go lower, like C0, your C1, C2, C3, C4, C5, C6, C7. So as you go lower, what happens to the flexion? You want the flexion is going to increase. So let's say if your upper cervical spine, you just need like a 5 degree of flexion. Then C3, C4 would require somewhere between 10 to 15 degree of flexion. Then later on, C5, C6, C7 regions will require around 25 to 30 degree of neck flexion. So as we keep going lower, and that's the main area that we give, right? Have you ever seen traction for C1, C2? Rare, right? Traction for C1, C2 is pretty rare unless and until you have like some significant headaches or cervicogenic headaches or something, right? So 25 to 30 degrees of neck flexion is what we are going to do when you're giving traction. Another thing, make sure that sometimes people have TMJ dysfunctions or something, so you don't you take care of that. Don't have them like or like something between their teeth. Or sometimes there are simple tractions which are called as like a hammock traction, which are just like a hammock, like a belt, and they just pull it. It's not like your usual cervical traction. So the different modifications are there. So TMJ dysfunction doesn't mean you don't give traction. You do give traction, but you can just modify it. Okay, that's about your cervical traction. Now, when it comes to lumbar traction, positioning, when would you do prone positioning? When would you do prone position when about lumbar traction? Excellent. Disc herniation. Otherwise, we are going to go to supine positioning. Okay, we have to open the foramen. Okay, opening of the foramen is essential. Now, again, we need to flex our hip. The more you flex, like it depends on the flexing of the hip, how much is the joint space going to increase. Same way like cervical, you don't want it to close, you want to open it. So when you are at a higher level, let's say you are at an L3, L4 level, what is the degree of hip flexion that is needed? You require 75 to 90 degree of hip flexion. If you so here it goes on decreasing as your level decreases. Okay, if you are at your L4, L5, it requires somewhere between 60 to 75 degrees of your flexion. If you're at your L5 to S1 level, it needs around 75 to 90 degree of hip flexion. Oh, sorry, 45 to 60 degree of hip flexion. I'm sorry about that. Okay, so as we go lower, the flexion is going to decrease. Okay, we don't really need 30 degrees. Okay, 45 to 60 degrees is good enough. Okay, Zeel, maybe it's like after that sacrum, you're not really going to give traction, right? But if you have been given 30 in your question, that means it's the lowermost level because least flexion is only going to be needed in the lowermost area, lowermost segment. Okay, so this is your degrees for your lumbar. Now, what is the weight? What is the percent? What is the weight that we give with lumbar? 50 is too much. We give 25% of the body weight. We always begin with 25% of the body weight. Disc herniation, all these conditions, we always begin with 25%. Unless and until they have specifically mentioned that you want the distraction of the joint surfaces. If you want distraction of the joint surfaces, you pick 50%. Otherwise, all your other stretching, disc herniation, anything they mention, you are going to stick to initial 25% of your body weight, okay, 25 to 30%. Again, they'll give you the weight of the person and they may expect you to put in the weight that is needed. When you give lumbar traction, they have a thoracic belt, they have a lumbar belt. The lumbar belt is at the iliac crest. PTAs, usually they can ask you positioning. Where is it? At the lumbar belt is usually at the iliac crest. PTs, I don't think they would ask such a simple question, but PTAs, they can put the positioning of the lumbar belt. That is at your iliac crest region. Okay. Yes, so another thing about traction. Okay, when do you prefer static traction over intermittent traction? Most of the time we are giving intermittent traction. When do we prefer static traction? Initially, when the patient is, let's say a patient is very acute and any movement is causing pain. Let's say if you're, that intermittent action of stretching, relaxing, stretching, relaxing, if that is causing pain or irritation, you cannot give intermittent traction and you have to move to static traction. Pillow placement, you have your hip are already in flexion, right? So pillow is usually under your knee. Depends on again what kind of traction machine are you using. If you're using those big pillows to maintain the hip flexion, then anyways your hip is going into flexion. No traction with lysis, listhesis. Ideally, no. Okay, I'm coming to that next is your contraindications. What would be your main contraindications with traction? Joint laxity, Down syndrome, or ligament instability, rheumatoid arthritis, osteoporosis, ankylosing spondylitis, right? That's going to be a problem. Fractures and ankylosing spondylitis. Pregnant women would be pregnant women also you don't want to because of their laxity. Yes, RA, very good. RA, ankylosing spondylitis, RA, Down syndrome, spondylolisthesis. Yes, spondylolisthesis. Nerve root compression is an indication, Vijay. Your nerve root compression means radiculopathy. It is the biggest indication of traction. Okay, so nerve root compression is always an indication. Radiculopathy is an indication. Muscle spasm, indication. Stiffness, indication. Okay, hypotone, Devanshi, definitely, right? You won't give. It's a neuro problem. It's a spinal cord injury or any kind of problem. Hypotonia, you are not going to give traction. Okay, yes. So whenever you have like muscle spasm, joint stiffness, or anything, your indication is traction. But if I say cervical myelopathy, is it an indication or contraindication? Contraindication. Cervical myelopathy is similar to a spinal cord injury. Okay, good. Now, again, in traction, to trick you, if I tell you that a person with rheumatoid arthritis, okay, let's say I give you which of this is an absolute contraindication. I give you options: ankylosing spondylitis, rheumatoid arthritis with cervicoatlantoaxial instability, and my next thing would be grade 1 spondylolisthesis. Now, what would you pick as something that I could allow myself to do traction? Allow myself to do traction. Really, you would allow me to do traction on a person who has atlantoaxial instability? Think and answer. Would you allow me to do traction on somebody who has atlantoaxial instability? If you do that, they're going to get a spinal cord injury. So if they give you such a question, that means they're giving you all contraindications, but they want you to see how smart you are or whether you can pick the safest option. Okay, exactly. And you lose your license. So you can say that maybe grade 1 listhesis is still safer, right? Grade 1, if I give a very low weight, I'm just stretching the structures. Even though I don't give it in listhesis, if I had to pick one, okay, in my exam, I cannot say no, not safe. There's no option to pick that. So if I had to pick one in an exam, I would pick the safest of all. You're an entry-level physical therapist. They don't expect you to go crazy. All right, make sense? So anytime you get contraindications, precautions, they are never going to be copy-pasted from your textbooks. You have to be smart in picking those, okay? So make a good clinical judgment. You guys are great. I'm sure you guys are going to make a good judgment. Right? So that was your traction. Okay, always remember cervical radiculopathy is an indication for traction, not cervical myelopathy. Never get confused. Myelopathy is upper motor neuron. Disc degeneration, we do not. Yeah, later stages or really old people, you would not give it. Divya. Okay. How do you guys feel about modalities now? Like after we covered all the modalities. There's no compulsion to say good, okay? This is 1 minute.